Good evening to all the viewers who are watching live and will be watching on the recorded version. This is me, Orko Mukherjee, with you with a brand new and grand CME to host. And we have wasted 3 more minutes and we are on a tight schedule right now. So, since you guys are waiting for this moment and many of you have contacted me, so I am about to start this. The main thing, what is to say, this e-participation certificate, it will be available after 8:30. So be there and listen to this CME. But before that, the main thing, which is the main back show of this, let's go to the 30 seconds countdown time.
Good evening, sir. Good evening,
Good evening.
everybody.
Good evening.
And today is an auspicious moment. We are slowly but steadily inching towards the centenary mark. And by blessings of our seniors and by the guidance of our beloved President, Dr. Debnaran Kalyani, and other seniors, the previous directors, and the stalwarts of homeopath, along with the present faculty members of National Institute of Homeopathy, we are in the 99th episode of our continued medical education program being organized by National Institute of Homeopathy Alumni Association. Sir, with your permission, uh, let us bring on tonight's inaugurator, the academic in charge of National Institute of Homeopathy, Dr. Chintamani Naik, sir.
Sure. Please call him.
Dr. Orko, can you please bring Dr. Chintamani Naik, sir? Good evening, Dr. Chintamani, sir.
Good evening,
Good
sir.
evening. Very good evening. Very good evening. Very glad to see you.
Respected Devnaran Kalyan sir and Dr. Vidyut Mukherjee sir for carrying out all this historic aspect. Today, the clinical case conclave about the success stories in homeopathy. And I welcome to all the 14 members, Dr. Tirthankar Banerjee, Dr. Mukesh Singh, Dr. V. Dhanalakshmi, Dr. Vivekananda Chakravarti, Dr. Somit Hajra, Dr. Pritha Mehra, Dr. Tousif Jamal, Dr. Sandeep Mishra, Dr. Parvez Ahmad Khan, Dr. Mahua Majumder, Dr. M.D. Naim, Dr. Subhamay Sarkar, Dr. Argha Chatterjee, and Dr. Kaveri Pandey. And apart from that, I also welcome to our moderator, Dr. Pranay Sharma. And without any delay, I'll be expecting that all our speakers today will enrich the session in a rigorous way about in presenting the clinical cases, and it will enrich to all our participants in this auditory, this aspect, those who are present in this conclave. So I welcome to all of the participants and members, those who are present over here. Again, without delay, I'll ask the members to start the session. Thank you, sir.
Are you audible, Pratha? Am I audible?
No, Pralay. Yeah, please.
Please start.
Over to you, Pralay.
I would like to welcome all of you in this special CME session. This is a session of clinical case conclave. We would say the success stories in homeopathy. And I am Dr. Pralay Sharma, too much honored to be your moderator today. This unique format where we will hear from 15 number of our distinguished alumni today. Each will be sharing their most inspiring cases and treatment success in just 5 minutes of time. The goal of today's session is to share knowledge and experiences in a fast-paced, impactful manner. Each speaker has very carefully selected a case that showcases the strength of homeopathy, and we are thrilled to learn from the success stories of each and individual speaker today. With this idea, with this attain, I would like to call upon over this stage, as I received the name as in sequence, Dr. Shamit Hajra will be the first speaker today.
Sorry to intervene, but I guess the first speaker was Dr. Mukesh, sir.
I was speaking to Dr. Bidut, but he did not respond well. But what I received in this CME one, Argha, could you please send me the revise the decision what you made for the flow of this?
Sure, sir. Sure.
First is
Dr. Mukesh, sir.
I would like to call upon over this over this CME session today, Dr. Mukesh Singh. He is from Delhi. We'll be honored to hear from him. Dr. Mukesh, please. Here is your floor.
Yeah, thank you, sir. Thank you to all my sir, Kalyani sir, and seniors, Dr. Mukherjee, Alka, Dr. Pralada, and all my juniors, seniors, colleagues. Today, I, Dr. Mukesh Singh, 5th batch NIH. मैं अपना शेयर करूंगा कि पाइल्स और पाइल्स से रिलेटेड जो भी डिजीज हैं, फिशर एंड फिस्टुला, ये सब चीज़ें जो हैं ये सब लाइफ स्टाइल डिजीज हैं और ये केसेस बहुत आते हैं क्लिनिक में और सभी डॉक्टर्स ने अपना एक्सपीरियंस किया है अपने अपने अलग अलग मेडिकेशंस में। और मेरा जो केस है वो अभी 3 महीने पहले एक केस आया था, रविंद्र सिंह, एज 35 ईयर्स है और वो ड्राइवर है, बहुत गाड़ियां चलाता है। तो वो पाइल्स और फिशर दोनों से ही था। डायग्नोसिस उसमें फिस्टुला लिखा हुआ है और आपका फिशर भी उसको डायग्नोसिस हुआ है क्योंकि वो थोड़ा सा पान वान और लाइफस्टाइल है, तो खाना उनका आउटसाइड फूड है। तो वो केस के लिए आए थे और काफी परेशान भी थे, पेनफुल था और बहुत ज्यादा पेन होने के वजह से क्या है कि वो ड्राइविंग ज्यादा नहीं कर पा रहा था, बहुत ज्यादा परेशान भी था क्योंकि वो सिटिंग उसकी बहुत ज्यादा है और ड्राइविंग उसकी कम से कम नहीं तो पूरे दिन भर में 250-300 किलोमीटर के करीब होती थी और खाना वो बाहर से ही खाता था। तो जब क्लिनिक में आया है तो उसको बैठना भी बड़ा टफ था, बहुत मुश्किल था और बहुत रेस्टलेस भी था। लेकिन उसको क्या है कि वो मीठा बहुत खाता था, मीठा मतलब स्वीट डिजायर थी और क्योंकि डायग्नोसिस हो चुका था तो मेरा डायग्नोसिस करने का वो था नहीं और मैंने उसके सिम्टम्स लिए, केस टेकिंग की है और उसको जो एक जो ड्रग पिक्चर निकल के आई है वो नक्सोमिका, सल्फर और जो सिम्टमेटोलॉजी अगर मैंने देना था तो वो मैंने डिसाइड किया था। तो फर्स्ट टाइम में जब मैंने दिया है उसको तो नक्सोमिका थी क्योंकि उसका कॉन्स्टिपेशन और जो डिजायर थी वो उसके बेस पे मैंने नक्सोमिका स्टार्ट किया और फर्स्ट फ्यू डेज में उसको एग्रेवेट हुआ। देन आई स्टार्ट द सेकंड मेडिसिन और उस टाइम मैंने दिया उसको सल्फर 30 की 3 डोज देके मैंने छोड़ दिया एंड देन he will start मेरे ख्याल से 7 दिन के बाद में उसने स्टार्ट किया, तो सेकंड डे वो फिर आया है कि कहने लगा कि वो बहुत ज़्यादा रेस्टलेस हो रहा है, पेन ज़्यादा हो रहा है, बढ़ गया है। तो मैंने कहा कि थोड़ा-सा वेट करो, आप बताइए फिर कि कहीं ऐसा तो नहीं कि मेंटेनिंग कॉज़ हो कि आप क्या खा रहे हो? तो उसने बोला कि मैं ऐसा तो आउटसाइड तो फूड तो मैंने बंद किया हुआ है, लेकिन मैंने थोड़ा-सा मीठा ज़्यादा मेरा हो गया है। और तो मैंने कहा मीठा भी तो आपका ज़्यादा ही बढ़ा रहा है, आप मीठे को कम करो। तो उससे मीठा भी कम किया। देन मेरे ख्याल से 10 एक दिन के बाद में फिर उसको मैंने मेडिसिन कोई नहीं दी, पेल दिया, सेक्लेक दिया, वेट करने के लिए बोला और पानी पीने के लिए बोला कि पानी खूब पियो। जितना पानी पी सकते हो उतना ज़्यादा अच्छा रहेगा, फाइबर चीज़ें खाओ, सलाद खाओ। तो मेरे ख्याल से 14 डेज़ में उसको थोड़ा-सा रिलीफ मिला। एंड देन स्टार्ट विद द सल्फर 200, 2 डोज़ ओनली। और सेक्लेक बना के दिया मैंने 15 दिन के लिए। तो उसके बाद से उसका 50% का रिलीफ मिला, लेकिन उसके बाद से ब्लीडिंग होने लगी है और ब्लीडिंग इतनी ज़्यादा होती थी कि उसको मतलब पूरा का पूरा बैक तो वो एक्यूट जिसे कहते हैं ना, हेमरेज टाइप का, हेमरेजिक पाइल्स जिसे कहते हैं, वो पूरा-पूरा हुआ। देन आई विल गिव उसको दिया था मैंने हेमामेलिस क्यू और रेटेनिया क्यू, ये दोनों मिक्स करके दोनों के लिए बोला। और आफ्टर 20 और 25 डेज में उसको ब्लीडिंग तो सब खत्म हो गया, पाइल्स में 60-70% के करीब रिलीफ मिला। एंड लेकिन उसका जो ड्राइविंग है वो तो उसको करना है क्योंकि अर्निंग भी है। तो उसको फिर थोड़ा-सा ये था कि डिस्कम्फर्ट फ़ील था कि एक तो कॉन्स्टिपेशन उसका ठीक नहीं हो रहा था, तो बहुत टाइम के बाद में उसको ये था कि उसको रियलाइज़ हुआ कि मेरी जो लाइफ़स्टाइल है वो थोड़ा-सा चेंज करना पड़ेगा। तो वो एक्सरसाइज़ वगैरह थोड़ी बहुत, क्योंकि उसका टाइमिंग ऐसा है कि मॉर्निंग कैब चलती है, इवनिंग तक चलती है, तो उसको थोड़ा-सा बोला कि थोड़ा-सा टाइम निकाल के कभी भी हो थोड़ा वॉक करो, एक्सरसाइज़ करो और सलाद ज़्यादा खाओ, दाल पियो चाहे भले से, लेकिन आपको सलाद ज़्यादा खाना है। इस वजह से उसको थोड़ा-सा अपना लाइफ़स्टाइल चेंज करने में जो टाइम लगा, उसी की वजह से उसको डिज़ीज़ का थोड़ा-सा टाइम लग गया। और ये सारी चीज़ें जो हैं ये क्लिनिकल में और इससे ज़्यादा मतलब उसको मैं ठीक इसलिए नहीं कर पा रहा था क्योंकि उसका मेंटेनिंग कॉस्ट था। क्योंकि वो ड्राइविंग कर रहा है, सिटिंग है, बाहर का खाना उसको पड़ ही रहा है, घर का खाना नहीं खा पा रहा है। तो उसके लिए मैंने उसको बोला कि भाई जब तक आप मेंटेनिंग कॉस्ट रखोगे तो आपका केस इतनी आसानी से ठीक नहीं होगा। आप प्लीज़ अपना जो डेली का रूटीन है, कम से कम उसमें अपना खाने का, बैठने का, सोने का आप अपना सुधारें, तभी आपको ये 100% रिलीफ मिलेगा, नहीं तो नहीं मिलेगा। ये एक मेरा केस है, और भी केस है, लेकिन मैं दूसरे डॉक्टर्स के लिए इन्विटेशन देता हूँ कि वो अपना प्रेज़ेंट करें। थैंक यू आरिक। थैंक यू सर, थैंक यू।
Thank you, Dr. Mukesh. It was wonderful to hear from you. It was quite insightful and it was well articulated to articulated presentation here today. And without further delay, I would like to call upon Dr. Tousif Jamal. Tousif Jamal to present his talk today.
Good evening, sir. Good evening,
Good evening.
everyone, respected seniors. Today, actually, আমি presentation কিছু বানাইনি। তা বাংলায় বলা যাবে?
না, হিন্দি হলে ভালো. It's good
Presentation
if you talk in Hindi
Okay.
or in English.
Oh, okay.
Okay, but your picture,
Presentation
your
কিছু
face is
বানানি,
not there.
তো
Okay.
Okay.
ठीक है, चल, it will go on. Carry on.
तो मैंने केस मैंने chronic case of dysentery, ये मेरा पहला केस था जो मैंने पहले बार फेल किया था, उसके बाद एक सक्सेस हुआ था, तो इसीलिए मैंने ये स्टोरी अब बोलना जा रहा हूँ। तो एक मेल आया था 64 इयर्स का, उसका कंप्लेंट था कि जो म्यूकर्ड स्टूल हो रहा है, तो बार बार नहीं हो रहा है, दिन में 1-2 बार ही हो रहा है। और एक कब से हो रहा है, वो कोविड-19 में इफेक्ट हुआ था। उसके बाद वो ट्रीटमेंट लिया था, और जो एलोपैथिक मोड ऑफ ट्रीटमेंट, वो मेडिसिन खाने के बाद वो जब कोविड ठीक हो गया, उसके बाद वो ये सिम्टम शुरू हुआ। तो मैंने केस लिया, लेके मैंने याद किया जो क्रॉनिक जो डिसेंट्री होता है उसमें चेपारो जो मेडिसिन है वो अच्छा काम करता है। तो मैंने उसको चेपारो 30 दिया था। तो देखा कि उसके बाद रिलीफ नहीं हुआ, तो मैंने थोड़ा सा अच्छे से केस लिया, फिर से देखा था मैंने मेरा कुछ स्किप हो गया कि, तो मैंने देखा कि उसका डायबिटिक था, हार्ट डिजीज था उसका, हाइपरटेंशन था, और जो केस हिस्ट्री था उसमें ऐसा था कि थर्मल रिएक्शन था, बहुत सेंसिटिव टू बोथ, और थर्स्ट बहुत ज्यादा था, टांग था मॉइस्ट, क्लावी, और टीथ इम्प्रिंटेड था, एपेटाइट था, ज्यादा भूख लगता था लेकिन खा नहीं सकता था क्योंकि खाने के बाद इंडाइजेशन होता था, और एवर्सन टू स्वीट था, और यूरिन उसका था फ्रीक्वेंटली अर्ज, स्लीप मस्ट टेक स्लीपिंग पिल्स नहीं लेता तो उसका नींद नहीं आता, और मेंटल माइल्ड पेशेंट था, जब बोलता था धीरे धीरे बोलता था, और फॉरगेटफुल था, कुछ याद नहीं रहता था, ऐसा कॉम्प्लेंट था उसका। तो मैंने पहले मार्क्सॉल 30 दिया था। तो उसके पहले मैंने मेरा बैचमेट से एक बैचमेट से स्नेहा से मैंने थोड़ा कंसल्ट कर लिया था, फिर उन्होंने बोला कि मार्क्सॉल ही सही रहेगा, तो मार्क्सॉल 31 डोज, तो मैंने 1 डोज ही दिया था। उसके बाद पीएल चला रहा था, तो मैंने बोला कि आप मुझे 15 डेज आफ्टर मुझे रिपोर्ट करो। तो 15 डेज आफ्टर जब रिपोर्ट किया तो बोला कि खूब माने बहुत ठीक नहीं हुआ, लेकिन लग रहा है कि अच्छा हो रहा है। तो मैंने फिर वेट किया, फिर उसके बाद और 1 महीने बाद फिर मैंने पेशेंट को विजिट किया। तो ये एक होम विजिट था, और पेशेंट को विजिट किया तो फिर बोल रहा था कि अब ठीक है, लेकिन स्टूल पहले 2-3 बार हो रहा था, अभी 1 बार ही हो रहा है, लेकिन उसके साथ कॉन्स्टिपेशन आ रहा है। तो मैंने फिर 1 डोज मार्क्सॉल 30 दिया था। उसके बाद फिर 1 महीने के लिए मैंने पीएल चला रहा था। तो उसके बाद पेशेंट कंफर्म किया कि अभी ठीक है, और उन्होंने ये भी कहा कि मैंने ये ट्रीटमेंट के लिए भेलोर तक गया था, लेकिन उसको वहाँ का डॉक्टर ने बोला कि ये आपका कोई प्रॉब्लम नहीं है, लेकिन मेरा जो प्रॉब्लम हो रहा है ये उन लोगों ने स्वीकार नहीं किया। तो इसीलिए मैंने होम्योपैथी का सहारा लिया। तो आज मेरा थोड़ा बहुत मैं बहुत ठीक हूँ, और थैंक यू कहा कि होम्योपैथी से मुझे पहले विश्वास नहीं था, लेकिन क्योंकि वो लोग बहुत रिच फैमिली है और रिनाउंड पर्सन है वो एरिया का, तो उन लोगों का होम्योपैथी का अंडरस्टिमेट कर रहा, मैंने ऐसा कुछ नहीं, लेकिन विश्वास नहीं था। लेकिन इसके बाद उन्होंने विश्वास किया कि हाँ होम्योपैथी में कुछ है। उसके बाद उन्होंने थोड़ा बहुत मैंने थैंक यू बोला। ये एक केस था, ये मेरे लिए बहुत स्पेशल केस था, क्योंकि वो जो पेशेंट था वो उसको मैंने कन्विंस कर पाया कि वो होम्योपैथी भी बहुत काम करता है। थैंक यू, दैट्स ऑल फॉर टुडे।
Tousif, Dr. Tousif Jamal, it was excellent to hear from you. It was excellent presentation on the treatment of dysentery case. Your detailed explanation of homeopathic approach and success you have achieved with your patient is truly commendable. It's always valuable to see how effectively homeopathy can address such a condition like a dysentery. And we appreciate your sharing and expertise in this platform today. It was quite good and wonderful presentation from your part. Tousif is very recently passed out, our ex-alumni. I believe that he's growing with his experiences. Now to continue this today's CME, I would like to call upon over this platform very experienced as well as very renowned physician of the country, Dr. Pritha Mehra. Pritha, here is your floor now.
Thank you so much, Dada. But I'm not renowned. I'm not very famous. Please, this is actually giving a lot of burden on me. Not like that. Thank you so much, and good evening, everyone. I proposed my name for making a presentation of a case. I don't know about the success story, whether it is a success story or not. But I really wanted to share something which maybe we all are facing in day to day when we are treating the cases, and also to give a small insight for the clinicians, basically, because I'm not into practice so much, more into the research and administrative aspects. So that's why. Arko, please allow me to share the slides.
Ma'am, just click on the present button. Just click on that
Yeah.
and then do the process. It will just come up. It will just show up.
Is it visible? Is the slides visible?
No, ma'am, not yet. As soon as it will be visible, it will be uploaded to in this over here.
Yeah, it's
I
processing.
think it is taking some time. It is taking some time. Just hold on until then.
So this is a case of chronic kidney disease. A patient, unmarried male of 24 years, height 5'4", and weight 50 kgs. Lawyer by profession, he came to the OPD on 19th of November 23 with the blood reports, and which was clearly reflecting that he is suffering from this disease. And the main concern was that the creatinine has gradually increased in the last 8-10 years. The blood report which he showed was creatinine was 7.5, urea nitrogen was 53.8, GFR was only 10. So clearly it's a chronic renal insufficiency. Phosphorus levels 6.89, the hyperphosphatemia. Calcium was 7.8, somewhere we can say hypocalcemia, and hemoglobin was 11.4. The USG report, it also showed that the right kidney was atrophied or shrunk and small, and the left kidney was also getting affected. When I asked about what are the major complaints, he said no such complaints, but he was accompanied with his parents. So the mother said that he has reduced appetite. He's not a good eater. He takes very small quantity of food, and he complains of nausea if food is not of his interest, and pain is felt in the bones if he gets hurt, and he has tendency to catch cold easily and takes time to recover. So this was the information which the mother has given. And on asking about the past history, there was bladder outlet obstruction at the time of birth and was operated for that, and subsequently at the age of 2.5 years or something like that, so he was operated for even patent ductus arteriosus in 2002. Physical generals: chilly patient, desire for salty food, momos, curd, sweat was only in the axilla and it was slightly bad smelling. Bowel movement, he said satisfactory, and he goes to the closet in the morning after a few minutes of waking up. Uh, Asking about how he is with the friends, family, and also it was again his parents, this thing that he makes friends very easily, and he was also very jovial while talking, and like he actually talked openly after that. And he mixes up people, he makes friends easily, and he looks for newness. This is what he said. Even being a lawyer, actually, he's assisting another senior lawyer. So he said, Ki, I like when a new case comes up and there is something new to learn about it. And I always look for, otherwise, it's a boring thing. I'll get bored. So then he feels tired as the working hours are prolonged, and that includes a lot of traveling time. Uh, as far as my observation as a physician, the face was pale, a few scar marks were there for the acne, tongue was clean, and he had quite long eyelashes. So, coming to the diagnostic totality, the common symptoms of CKD, we know anorexia, nausea, bone pains, which were there in this case as well. And laboratory and radiological investigations also indicated this renal insufficiency. Coming to the therapeutic totality, it was not I didn't repertorize this case, but analyzing the symptoms which were peculiar for this case, the tendency to catch cold, chilly patient, desire for salty food, desire for change as and active, alert, and long eyelashes. So this is what I considered, and considering the pathology. So considering these two aspects, I have prescribed Calcarea Fos 203 doses, TDS for 1 day only, and then Zingiber mother tincture, 10 drops in half cup of water twice for a month, twice daily for a month. So the laboratory investigations, with which they had come on 17th of November 23 was what I have told in the first column. And again, they repeated this investigation after a month. The creatinine remained 7.5, whereas and also the urea nitrogen, GFR was 10. Phosphorus from 6.89, it dropped to 6.3. Calcium 7.8, say 8.3. And hemoglobin 11.5, 11.4, 11.5. Not much of a change. In February 24, the creatinine came down to 7, urea nitrogen 52, GFR remained 10 only, and the phosphorus level again it dropped to 5.18, calcium improved to 8.3, and hemoglobin also improved to 11.9. So considering like this kind of a result, I was happy, of course, and the patients parents were happy. But subsequent to this February last, the patient did not report any symptoms. Within this 3 months of treatment, he did not report of any symptoms related to cold and cough, even though it was very cold in Delhi at that point of time. Then improvement was also noted in the lab parameters, which I have showed just now. But the patient was lost to follow. There was some demise. Somebody died in their family, and they had to go to the village, and subsequently could not. He didn't came back. He didn't come back for any follow up. However, telephonically I tried once or twice, and subsequently like they didn't turn up. So my two concerns over here were like why when this kind of improvement happened, but I lost it. Whether I should tell it as a success story. But yes, of course, what I got the confidence was that understanding when the renal function is disturbed, the renin-angiotensin system, this mechanism also gets disturbed. So there will be a fall in the hemoglobin. Then calcium, phosphorus imbalances are also there. But with this secondary thought came that Calcarea Fos, as we have all have read also, that this brings back the absorption and release of these minerals in the system. So that also has helped. Whether I should have gone with the LM potency in such cases, that should have been a better choice. This is another learning which I felt is there. And however, the question is like to understand the mechanism of action of homeopathic medicine, which is still to be answered. One request which I would like to make to all the presenters, that we have certain case reporting guidelines and assessment tools which we all should maintain with us, and this is home case care guidelines, and there is a modified Naranjo criteria Monarch tool, and there is a patient response assessing tool after homeopathic treatment in chronic cases. So these tools are very, very important when we are saying about success stories. Using all these and reporting our cases in this manner will be of much help. This is the modified Naranjo 10 domains and the scoring system over there. And there was the Herring's Law of Cure. Herring Law assessment tool was there, which was revisited, and it was made as this patient response assessment tool after homeopathic treatment in chronic cases. So this is the flow chart for how that response is to be assessed and analyzed, apart from whatever insight we already have about the case. So thank you so much. That's all from my side.
Thank you so much, Dr. Pritha, for your very comprehensive and talk into this subject. Once you were saying that this patient took a treatment and somehow the patient is not reporting nowadays. So this is a very common phenomenon in case of treatment of the chronic renal failure. In fact, what we observe even in our hospital setup too. In fact, your patient was in with EGFR 10 means is a stage 5 chronic renal failure, and what you call as a end stage renal disease. The what I learned from my experience, and I would like to share this my idea as a moderator here today, that in case of renal failure patient, they often die because of the cardiac failure. It can be a left heart failure or it can be ischemic heart disease. So once we get a patient of this CKD patient, we give much of attention over this left heart failure because this PND attacks are very common into it. So you cannot predict this PND attack. A CKD patient, you cannot never predict that when it will occur. And the middle of the night too, that usually occurs. And you do not know that when it will occur, and there is as such no prevention too. So it's up to the luck of the patient, in fact. So in modern medicine, they keep on giving this diuretics, and very often they keep on going the diuretics. We also do have a certain diuretics, but it is to apply the diuretics. Again, you are applying some agent which disturbs renal function. So this is being the factor that is not to you; it happens to all of us. In fact, across the country. But it was quite informative, and this our new generation will get much encouragement by your talk today. And very thank you so much for sharing the view that everyone should use the tools of case success stories by which we can document the cases. I'll request Dr. Pritha to share this your format of this such information to put in our WhatsApp group so that everybody can see this.
Sure, Dada. I'll share that, and thank you so much. And I would like at the end of this CME to give some more insight into the use of mother tinctures, because over here Zinzibar I used understanding that
No,
complete cessation of function
Pritha,
of kidney. This one sentence. So
so
I would request.
Pritha, are you asking me to put some mother tincture into it?
No.
Asking
I'm
me?
saying that give some insight about the use of mother tinctures also in such cases. After the
Yes, yes,
CME,
yes.
and at the end of CME, if you can give
Yeah,
some
yeah, yeah.
further guidance
Sure,
on
sure,
this.
sure, sure,
Thank you so
sure.
much. Thank you,
Thank you
everyone.
so much. Thank you so much. Thank you, Pritha. It was a wonderful talk from Dr. Pritha Mehra. Now I would like to call upon this over the stage Dr. Mahua Majumder. Dr. Mahua,
Uh, please just wait. Moa ma'am just went away. Can we just go on to our next speaker,
who
if
is
possible?
it? I have to find the next speaker. The Orko, who is the next speaker? Could you tell me? I'm just
It's
one by one.
Dr.
I'm trying to
Tirthankar
get it.
Mukherjee. Hey,
Huh?
Dr. Tirthankar, I am sorry. I am very much sorry. Dr. Tirthankar Banerjee.
Dr. Tirthankar
Just
Banerjee. May I request Tirthankar to be on the podium?
Sir,
Dr.
hello.
Tirthankar,
Yes, sir.
Tirthankar Banerjee.
Good evening
Here
to
is your
everyone.
floor. Please carry on.
Okay, first of all, I would like to ask sorry for everyone that I wasn't be able to maintain properly create a slide reviews, but I just shall be sharing cases from my enclave and from my archive here in my computer. Hello everyone, myself Dr. Tirthankar Banerjee. I'll be sharing two very small cases which will be helping us in future prescription of certain medications and in certain situations. So one of those medications which we use very less these days, partly because we do not have any clear indications, and partly because we do not have that much of access in those medications, and partly because of our ignorance. So today I'll be sharing two cases of apparent failure of well selected homeopathy medications, rather to be said in very well selected homeopathy medications failure, but got extremely well tackled by another medicine which is comparatively less used, do not have much indications. Even after searching for in books and books after, I only be able to find only one indication of from that medicine, that is actually not a prescribing indication. So in bottom line of this case, of these two cases, what I wanted to share is that it may so often happen that we do not get a very clear indication even in either in a patient or in certain medicines, lesser proved medicines, I would say. So in those cases, often conjuncting the case picture, the clinical scenario of the case and the predicted scenario of the medicine can be matched, can be tried. So the first case, I'll be sharing a short detail of the case. The case is of a Bengali unmarried boy who was around 26 or 25 years old, visited me at the very beginning of this year. So what was happening? He was being treated by modern medications for a long time, for around 2 years or 3 years, for his apparently very small but very troublesome complaint. That is the complaint of recurrent acne. And then what happened? Then after the acne were faded by use of antibiotics, salicylic acid, tea tree oil, etc., the marks remained. So up to that, things were very good. But then right after he stopped taking those antibiotic medications he was being taking that for a pretty long time, for around 2 years or 3 years. So what happened after he stopped that? 2 months after that, he got diagnosed with MODI. He got diagnosed with maturity onset diabetes mellitus, and his initial blood sugar, as I got the report, was around 226. So he was sent to a physician of endocrinologist, and he started giving him medications, and his blood sugar literally went down to an absolute base level, normal level. So he was quite fine with that. Then the second problem came, where from the homeopathic challenges started coming. He started developing boils all over his body. So those boils were extremely painful, and some of them were having absolutely no pain. But the most common thing was that they were all purulent boils. Those boils started affecting in the front part of the trunk, and then in the lower back, in the iliac fossa, and finally they got settled over the shin bones. So now what happened, every time I prescribed based on his constitution, calcarea phosphoricum, silicea, hyposulfuris, mark salt, etc., those improvements were only an improvement of maximum 7 to 10 days. Those boils, those were coming out, they got erupted, absolutely healed, then again came back, then again came back, then again came back. And now every time they were coming back with more fulminance. The patients later on, the patients in 2 to 3 weeks, the patients started having fever, like septicemia like syndromes, and his CRP was also high. If I cannot remember, I cannot procure the report exactly, it was nearly 30. His procalcitonin level were also high during the level of fever, during the episodes of fever. In that situation, he had a boil. I will not say that was limited to the name of boil only. By that time, it has turned out to be a carbuncle. It was extremely painful, and the entire surrounding was cellulitic. The patient was absolutely malaced, constitutional upset were there. I'm not sharing much of a prescribing symptoms because there were none. As per I investigated, I couldn't get any prescribing symptom. I tried with all the medications which are very well known for purulent conditions, infections, Even I tried doing with staphylococcinum, streptococcinum, pyrogenium, etc. no sorts, but without any response. Then patient went to another physician, a dermatologist. He gave antibiotics, and these times antibiotics absolutely went down. These times antibiotics also failed. So the patient again came to me, and with my utter surprise, I saw the situation was like this. Uh, how to share the screen? Orko, can I? How can I share my screen?
Just click on this present button. Just click on that.
Okay.
After
Oh, share
clicking,
screen.
just
Okay,
click
I
on
got it. Got it.
share screen.
Got it. Got it. Got it. Okay, got it. Thank you.
Just do the entire screen part.
Okay. Can you? Is it okay now? Screen. Okay.
It's currently not showing. I guess you have to click on that. The
Probably.
same
Probably I
process.
got it. Probably I got it.
It's now visible. Just click on the slide.
Okay.
Just open the
Okay.
slide. Then I will just bring it up on screen.
Okay. 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 Should I continue now?
Sure, sir. No problem.
Okay. Okay. Thank you. So here is the situation. Is that this was the initial situation when the patient came after the intervention from a dermatologist. This is the situation when the patient came. So here he was absolutely, his entire area was cellulitic and it was past discharging. Probably an antibioma, subdermal antibioma was formed after taking antibiotics. And this was the situation, and this was not improving for 10-15 days. His CRP remained high, his procalcitonin remained high for like around 4-5 days. Then the CRP and then the procalcitonin and procalcitonin even came down to normal, but his CRP remained high. So here is the situation. So I got only one indication from of this drug, which I'm going to share with everyone who are stuck and probably unfortunately going to get stuck in this kind of situations where all our known medications like Hepasol, Marxol, Pyrogen, Asal, Anthracinum, everything is likely to leave your hand. This time I request all of my fellow colleagues to have a try with the terramycinum. I started with terramycinum. And then after giving terramycinum, in 3 or 4 days, the situation came down to this. Sorry. Then after 1 or 2 days, and this time no other medications were given. No calendula dressing, no arnica dressing, no dressings, nothing was there. Just only warm water compression and just keeping it open. And only he was taking this terramycin 200. Probably I cannot exactly remember the dose, 2 or 3 drops once daily. So by 6 or 7 days, he was absolutely fine. And at the most, with my absolute grace, that he from that time, it was a case of probably in March. After from that time, he didn't have a single episode of. He didn't have a single episode of. He didn't have a single episode of bowels. Second thing, the second case I wanted to share in a very small, short span of time, which is the same case again with terramycin. So this time again, I got another infected sebaceous cyst from a patient who is an MS PGT in a medical college in Kolkata, and she got this sebaceous cyst, and she was about to get operated. And then she came because she tried to have a second option before getting operated on, before getting enucleated on. And then again she was having more or less this kind of picture, except for the fact that she was never diabetic. So again I tried with Hepasol, Marxol, Silesia, and then absolutely it all went in vain. So again, I got another miracle. And if anyone wants to ask me that what is the indication of terramycin, that is going to share at the very last of this presentation, which is going to disappoint all of you. It has disappointed me also in a way. Again, I'm sharing the screen. Okay. Okay. Orko, I am sharing the screen now. So here it goes, the first situation. It's a very simple case. Busting a sebaceous cyst out, which I posted in my social media handle also. Busting an Orko, is it visible?
It's visible. It's visible. Just continue. It's
Okay,
visible.
thank you. Thank you. So, busting a sebaceous cyst out, inoculating a sebaceous cyst medically, homeopathically is not much of a big game for any physician. Most of us have done this for a long time. What happens when all the classical arsenals that we have leave our hand? The problem starts there. When we cannot make a cyst mature, when we cannot make a cyst enucleate itself with heparin, silicea, marxol, arsenic album, anthracinum, etc., so on, then what happens? Even the constitutional drugs also started failing. Even the nosodes like staphylococcinum, etc., also fails. So there is a situation when this kind of drugs, which are derived from substances of modern medicine, potentized and obviously not much proved yet. So this is the situation of Dr. Das when we saw her. This is the situation of Dr. Das. She was having, she was not icteric, she was not pyretic, she was just having intense pain. So after giving that drug, this was the situation in probably in 2 to 3 days. After 1 week, the situation came out. The whole entire capsule started coming out. The most important thing is that when this capsule was starting getting enucleated, then she developed fever. So that is the point when I was very afraid of to know whether she has got a secondary infection, or she should be asked for to take antibiotic coverage or etc. But she insisted that no, you can continue, because she was good, she was very happy with the results. So this is the moment when I prescribed her arnica 3. so so prescribing arnica 3 is a very small indication, which I personally used arnica 3 because arnica has a power to prevent any pus forming infection. So just based on that, I gave her arnica 3 size daily, probably 15 drops, 10 drops, TDS I prescribed. Along with that, she was being given terramycin in 1 or 2 days interval. So after that, the situation was like that, and it was an wonderful non-scarring healing. And as we can see here also, that here also we can see that by that time the capsule got enucleated. In the meantime, from the base, the granulation tissue has also formed, and this is a very healthy granulation tissue where we can find out the newly forming blood vessels, and absolutely clear sera is also found. Now, this is the situation when gradually the granulation tissues causing secondary healing, and also the fibroblastic activity around the wound is taking place. And this is the moment when I stopped giving all medications. She was just asked for calendula ointment dressing, and this is how it went off. So, I am at the very end of my speech. I'm very sorry I couldn't be able to make a proper presentation out of this, but hope this will help my fellow colleagues. And now everyone will be asking me that what are the indications of terramycinum. Frankly speaking, what I got is that terramycinum, I couldn't get any indication except for the traditional indications of terramycinum. Firstly, the patient can likely be a diabetic patient. First thing. Second thing is that probably terramycinum is a broad spectrum homeopathic antibiotic or bactericidal, I'll say bacteriostatic agent for situations when the case got stuck with streptococcus, staphylococcus, Haemophilus influenzae, specifically Pseudomonas aeruginosa, where the pus is green in color, type of infections. So now, where did I get terramycin to read from? I couldn't get any proper hint to read terramycinum from. I just knew that some good pharmacy makes terramycinum. And then I tried to have a study on how terramycinum works in conventional medicine and how I can use that knowledge of particular type of pus formation, particular type of infections, particular type of conditions where modern medicine uses terramycin, get that from homeopathy pharmacy in potentized form and prescribe that on. So now the biggest thumb line, bottom line answer to this is what is the indication of terramycinum? The indication of terramycinum is two. Number one, get a basically an oxytetracycline sensitive organism infection. Number two is most important. When all your selected classical homeopathy medicines are leaving your hands, that's the two indication to give it a try with terramycinum. Prescribing only on one point, prescribing only one case doesn't give any evidence-based idea of how a medicine can act. But giving 2 or 3 cases where the results is reproducible, where you have failure with all your previously known homeopathy medication indications, then giving something new to the patient which literally has no indication apart from the failure from failure with other medications, that is the only probable indication with a classical, with the characteristic type of inflammation, with a characteristic type of pattern in infection like streptococcus infection, staphylococcal infection. However, terramycin is mostly suited to staphylococcal infections and specifically Pseudomonas aeruginosa infections. One indication that I get can be assessed and can be extracted as number one, that all your medicine are failing you. Number two, it's a bacterial infection. And number three, it's likely an infection where you expect green, yellow, or greenish yellow pus. Thank you, everyone. Thank you so much. Orko, I am done.
Dr. Tirthankar, it was a wonderful presentation. It was quite insightful. But I do have one question to you, Dr. Tirthankar, that the first case you said the patient was tackled with the terramycin is a wonderful one. But you at the same time said the patient was diabetic at the onset of the diabetes. What happened with the diabetes? If whether the patient was continuing modern medicine for diabetes or it was tackled with homeopathy?
Okay, sir. No, actually, what happened, sir? Initially, when the patient got diabetes, it was like around in the previous year, in 2023, he got diabetes. Then modern medicine treated it. And then the physician of modern medicine said that, okay, you do normal diet, exercise, and I'm not going to give you any medications because you don't have a family history of diabetes. So at that time, when I got the case, he was non-diabetic.
I got it. It was excellent, Dr. Tirthankar. The way you address the early intervention and treatment strategies was particularly informative. Your timely intervention into this disease process was a wonderful one. And the second case was again a wonderful one, and you have very nicely narrated the indication. In fact, sometimes we do get the literature-based indication. Sometimes we do have experience-based literature. Your observation regarding that terramycin was a wonderful one. I believe that the viewer who are watching this webinar today will be trying this medicine in near future. Thank you so much once again. Now to continue the CME, I would like to call upon Dr. Mahua Majumder. Is she there? Yeah, Dr. Mahua. Please continue. You are not audible, Dr. Mahua.
Okay.
Please unmute. Yeah.
Yes. Thank you so much. And I am thankful all of you that you have invited me to join this group. And as it is a short time, I have not made any kind of that PPT or like this. But I like to share a case in that was in my first time doing the chamber in my practice life, that like to say 20 years ago, like that time this case was happened to my chamber life, and as it is a memorable one because it's a very acute case, and it's a really memorable one, and that's why I want to share. It's a very small drug that I mean it is not used frequently. That drug is iris verse. I have mentioned this drug, and the case is like that. I used to go to my chamber in the morning, and I saw that a cobbler who was beside the road and sitting in a small shop, working with his daily jobs. And one day, when he rushed in my chamber and said that with agonizing pain in his abdomen, and he just moaning with this pain, and he requests for something to do to his pain. It was a very acute condition, and first at that time I was really unexperienced and not ever tackled in any kind of these cases at that time. But that time suddenly the pain, the character of the pain, and there is a huge burning in his abdomen. And on seeing these two symptom, and there is a past history of he was a drunkard. I mean, he used to have alcohol every night. I gave him Iris verse 6, and after having this medicine, he can't sit due to his pain, severe pain in his abdomen. He said that, ma'am, I have to lay on the floor of my chamber, and he laid over there. But after few minutes, he was in a deep sleep. Sleep like that, I can't made him awake by calling him. And the memory is that after a very refreshing sleep, he waked up and have no pain in his abdomen. But that the condition, that sleeping condition, that made my time for closing my chamber a little bit longer. And this is a very remarkable case to my experience. As we all know that if the medicine act correctly, the other indications like food, I mean appetite, thirst, stool, bowel movement, and sleep, at all these get improved. But the moment when he slept in a deep sleep, and the peacefulness of that time, his appearance, it was really happiest moment of my practice career. And as the drug is not used so much, but it did a miracle one that time. And there is so much, I mean, cases are there, but now I have only this one. If that you permit, and I will prepare my some other cases to you. Thank you so much. Thank you giving this time to me. Thank you so much.
Thank you, Dr. Mahua. It was nice to hear from your side. Dr. Mahua shared a very wonderful case, and she shared a old case. And old case has always been kept well in our mind. Whenever we talk in a seminar or conference, you will see all of us will share some of the cases which are very, very old. These are never forgettable. She came across a patient who was having acute abdomen, and that too in an alcoholic case. And treatment with iris var has given a relief, and that is the way she managed the case of acute abdomen. And every day, in fact, we keep on doing such endeavor for relief of the pain of acute abdomen, in fact, in our daily practice as well as in hospital practice too. Thank you so much once again, Dr. Mahua. Let me call up on the stage the very experienced person. I would like to say one point, that I'm not saying the biodata or the CV of the speaker today because of the constraint of pain, because I have to keep on saying the many of the degrees and the experience what one speaker do have, that because of time constraint, I'm purposefully deliberately avoiding that. Let me call upon this time Dr. Sandeep Mishra, uh, a renowned physician. And Dr. Sandeep, please, here is your floor.
Thank you, Dada.
Thank you so much.
Arko, please start my PPT. First of all, I would like to thank the organizers
Sorry to
for
intervene you, sir,
initiating.
in between. I am extremely sorry to intervene you, but you have to again upload your slide because your slides is not being showing on the background. Can you
Okay.
please just re-upload it again if possible? Sir, it's on now. Over to you.
Okay, thank you. First of all, I would like to thank the organizers for initiating such a valuable series. I must congrats to reach the milestone of this, nearing towards 100 episode. It is a testament to your dedication and devotion. Dear professor, today I may take a bit longer to present my thoughts. So I kindly ask for your patience and understanding. Thank you. Dear friends, I understand that what I am discussing might seem unrelated at first, but I assure you it's directly connected to today's topic. I will sharing my clinical experience to illustrate the patient I want to make, and by the end you will see how it all ties together. Dear colleagues, today I will presenting a case on urticaria. If time permits, I will cover two cases that illustrate the evolutions. Sorry. Just a minute. State the in approach to the condition. The first case dates back to 15 years ago, before 2009, when I was still developing my skill as a homeopath. The case will offer insight into my early approach to treating urticaria. The second case is from 2019, a potential period when I had established myself as a practitioner. This more recent case will demonstrate how my methods and understanding of urticaria have evolved over the years. By comparing these two cases, I hope to shed light on the advancement in my practice and provide valuable insights into the management of urticaria. Thank you for your attention, and I look forward to discussing these cases with you. 15 years ago, a renowned businessman from Kanpur came to me seeking treatment for urticaria, a condition he had been suffering for 5 years. He had previously sought treatment in various metropolitan cities, not only one city, different cities across India, and had tried different medical approaches, including homeopathy, without any relief. Despite relying on two anti-allergic medication daily, his symptoms persisted. He came to me hoping to find a solution to his ongoing problem. During the case taking, it takes around half an hour. The patient mentioned that his problem began 5 years ago. He traced the onset of his symptoms to a particular incident. While traveling from Guwahati to Kanpur on the Rajdhani Express, he was given a wet blanket by young attendant for some reason. After using the wet blanket, he noticed his symptoms started the next morning and have been troubling his ever since. I interpreted the cause of the urticaria was triggered by cold and damp condition, as urticaria is often aggravated by such environments. Based on this, I prescribed Dalkamara 30C. My doses you can see to be taken 3 times daily for 1 month. As patient began to show improvement, I adjusted the treatment to other suitable remedies. I know you know very well what are these medicines are. NIH and other medicines. Within 3 months, the patient reported being 90% better, and by 6 months, he was perfectly well. He is now 75 years old and remains symptom free. The second case occurred when I was established practitioner, and I must admit that during this period I was bit more relaxed, less diligent than I should have been. I am sharing this experience to highlight a valuable lesson. Despite having experience, it is crucial to approach each new case with the same level of energy and thoroughness. Our teachers always emphasize that every case requires a meticulous case taking and focused attention regardless of our experience level. The entire family is my patient, so you can understand my confidence level. A 17-year-old girl came to me with a case of urticaria that appeared every morning and gradually disappeared after about 3 to 4 hours. Initially, she did not pay much attention to the problem and tried some allopathic treatments for quick relief. However, when her symptom persisted, she decided to explore homeopathy, as she was now ready for more comprehensive approach. Her parents had previously suggested homeopathy, but she had opted for allopathic treatment initially. Now she was open to trying homeopathy for more lasting solution. Initially, I prescribed after taking Natramune and other medicine to the patient, but there was no significant relief. Over the course of 6 months, I adjusted the treatments and changed 3 different remedies based on her ongoing symptoms and response. While there was intermittent relief, the case required careful monitoring and adjustment to achieve better results. As a private practitioner, you can understand my mental status. Although the initial response was only slight improvement, I gave her confidence. It gave her confidence that she would get better, especially since she had limited option at that time. बीच बीच में she is taking allopathic medicines, but she know what is going to be. During the course of treatment, I observed that her symptoms tended to worsen whenever she received good news or gifts. Additionally, her urticaria, characterized by itchy, blotchy, swollen skin eruptions, was notably aggravated by sweating or wearing tight clothing. Despite 6 months of treatment, there was no remarkable improvement. which concerned me about where I might have gone wrong. During a follow up visit, the patient came with a mother who revealed that the patient frequently experienced diarrhea before her menstrual cycle. Often she medicated with allopathic remedies. Considering the potential side effect of these medicine, her mother decided it would be prudent to address the diarrhea with homeopathic remedies as well. This approach might help manage her overall conditions more effectively. As soon as I heard about the patient diarrhea occurring before her periods, I consulted Boric Materia Medica and reviewed the symptoms of Bovista. The symptoms matched those described for Bovista, which led me to consider it as a potential remedy. I decided to study Bovista in more depth, but unfortunately, the onset of COVID-19 and patient was no more pandemic and that plan was disrupted. The key message I want to share that even when a patient periods or her other conditions are regular, they they think its thirst is normal. It's crucial to thoroughly investigate all the symptoms rather than assuming the issue is. Sometimes we think a patient is all right and it is just psychological. Never be reluctant to delve deeper. Always search for specific symptoms that guide your prescriptions. Search for your failure. What is the cause of your failure? As though thorough case analysis can reveal underlying factors that may not be immediately apparent. My dear friends, I request you all to attend or join or share your experience. Why this is important? Because knowledge exchange is very important. It will always improve our knowledge, like metacine, calcarea for sulfur. We learned a lot. Those who are doing private practice, these medicines always give a confidence, like CKD case. I have patient. It will again increase my confidence to see more cases of CKD. Encouraging professional growth, this is very important, and the most important thing is sharing experience to build a sense of collaboration and support, especially for newer practitioners who benefit from the insight of more experienced colleagues. In summary, sharing clinical experience is very important for all of us. And one thing that is very important, this there is may be possible when somebody asks why you prescribe Dalkamara, why you didn't prescribe Netramure, why you prescribe sulfur, why don't prescribe sulfur. There may different question people may ask, and this is always possible that I am not able to answer all these questions. This is not a very important if I am not going to able answer of these questions. The most important thing, when I will search answer for those questions, will always increase, enhance my knowledge, not going to decrease my knowledge. So I request all of you, please come forward and share your experience. Thank you, Dada.
Dr. Sandeep. Dr. Sandeep, as usual, uh, thank you so much for your presentation, and you have detailed and you have given an insightful presentation on the very challenging case of urticaria. In fact, many of the patients uh, do seek the help from homeopathy for this recurrent illness of urticaria, in fact. And they all been in anti-allergic drug. To get rid of this anti-allergic drug, they often seek help from homeopathic concept. Uh, Urticaria is a issue that disturbs the day-to-day life of a person. And in our experience too, we do have many cases which has been treated with Bobista, in fact, to challenge with the urticaria patient. And what I find in my experience, and I would like to share as a moderator to here today, if you would like to get a complete result from Bobista, you have to begin with Rustox. Rustox, Bovista, then Rustox can make a wonder. And moreover, this, if there is acute exacerbation of urticarias, particularly in the form of the breathlessness or wheeze, or in the form of angioedema, which you can get under the eyelids or the lips swollen up and patient of distress, and that has to be tackled in on emergency basis. And if there is a exacerbation of the itching, uh, we always prefer a drug what we call as antipyrine. The antipyrine does have a wonderful tackling capacity in the acute exacerbation of the urticaria, particularly when there is a wheeze and particularly when there is angioedema. We can talk into it in details in further session, that we can talk on urticaria, because this is a very challenging one. I believe that the talk of Dr. Sandeep will encourage all of us to tackle the case of urticaria. In fact, thank you so much, Sandeep, for being with us. Thank you so much. Let me call upon Dr. Argha Chatterjee. Dr. Argha, are you there? Dr. Argha, please.
Yes, sir.
Please, please.
Are my slides there, Arco? Yes, thank you. So today, good evening to everyone. And again, I would like to extend my gratitude towards the whole Alumni Association, and as well as Dr. Prahlad Sharma sir, as always, for giving an opportunity to present a case. So today we are going to talk about use of Lachesis in salivary gland stone. Now, salivary gland stone, Orko, I can't move the slide. Uh, can you just go through the slides one by one? Yes. So the first thing is, while talking about salivary gland stone, we have to talk about cellulitis, which is basically the inflammation of salivary glands. Salivary glands basically, it just, let me get a is it, just give me a second. I hope I'm visible properly. Yes. So basically, cellulitis or inflammation of salivary glands basically presents with swelling of salivary glands with this intense amount of pain and also sometimes passing of pus through salivary glands. So this is about salivary gland inflammation. Now, when we talk about salivary gland stone, that is basically salivary gland inflammation might be of three types: acute, chronic, and recurrent. And when we talk about this salivary gland stone, is called Cellulitis, which is again presents with the same kind of symptoms, that is pain, tenderness, swelling of the glands and face, and difficulty swallowing. And also there is also at certain times, due to blockage of the salivary tract, there is less secretion of saliva and there is dryness of the mouth. So whenever we get a case of salivary gland stone, in most cases we get a report of basically cellulitis, that is inflammation of salivary glands. That is because in most cases, in these two occur almost at the same time. These two actually basically causes, means the both inflammation of the salivary gland uh, means contributes to the formation of the stone, and also the stone also contributes to the inflammation of the salivary glands. The treatments generally possible for this salivary gland stone are generally observation. Second is warm application. Third is a little bit massage. Antibiotics are generally given, or generally surgery is done. So basically, there is no conservative treatment other than surgery in case of salivary gland stone. Now, basically, in this kind of cases, in most reports, we are always going to find uh, salivary gland stones. Basically, we are always going to find cellulitis in reports, and then that's because in wherever there is salivary gland inflammation, it hides the stone in most cases. So now let's move on to my case, which basically a 61-year-old female consulted me online, and she presented with painful swelling in the left side, pain which was radiating towards from the to the ear. And second of all, there was swelling. She had got difficulty swallowing both solids and liquid, and also empty swallowing. This swelling was on the left side of the throat, and we proceeded further. Patient was on painkillers. She was in constant pain, and this for her, this was a chronic recurrence. She had a case of chronic cellulitis. So after taking the case, we did a repatriation, and then I can move the case. As you can see from the report, it is basically saying about cellulitis mentioned in the reports. So first, when we started with the case, it was a case of cellulitis. So on the basis of symptoms, as you can see the swelling in the patient's face, I have covered the eyes for privacy purposes. And on repatriation, basically, you can see on the first it's belladonna, and the second, both belladonna and lachesis are of the same grade. But in this case, I chose to stick with lachesis rather than belladonna. After I prescribed Lachesis 200, 4 doses, sorry, 6 doses actually, morning and evening for 2 days, sorry, for 3 days. In the first day itself, after giving Lachesis 200, the pain had reduced quite a bit, and the patient was no longer taking any painkillers. And after that also, basically what happened after the second day was that she developed a swelling below her tongue. Let's see the swelling. As you can see, there's a little bit redness just below the tongue where the salivary duct is opening. That confirmed me more that it was a case of salivary gland stone rather than just the inflammation of salivary gland. I thought in this on the third day there was no pain. On the fourth day, basically, uh, I just advise the patient to take a little bit warm application over this area and do this basically massage, which is indicated in case of salivary gland stone, so that the stone moves forward. After that, basically, what happened, the stone came out. This was a stone, and in when the stone was passing, she had a episode of pain, during which she called me up, and I thought of giving her belladonna 200. And I also actually advised her to means buy a belladonna 200. But before they could even come home with belladonna 200, the pain had subsided as the stone has passed away. Now the patient is, the glandular swelling is gone, patient is normal. On the second and third day, she was able to have liquid, solid, and everything. Her salivation was also normal. Only during passage of this stone, there her salivary duct was obstructed, and hence there was dryness of the mouth and good amount of pain. But still, she did not have to take any kind of painkillers. So this is not the first case of salivary gland stone in my practice. In Again, the reason for selecting lachesis was not just based on the clinical symptoms, but also other symptoms were also present, that she could not bear anything around her neck, anything tight would cause pain. And also the other part was that without this, before this, all this pain and everything started, she is a very jovial personality. She likes to talk a lot with all her family. So these were the certain points which I even added to prescribe lachesis. The last part is that even in cases before this also in salivary gland stone, I have seen, especially whenever the swelling is on the left side, lachesis has helped more than belladonna to get this stone out. On my first case also, I used belladonna first, then I had to come to lachesis, and lachesis was the medicine which actually got the stone out. In this is, I showed that case to Dr. Prahlad Sharma sir also 2 years back. I showed sir the stone, and also this time also basically the stone came out only with the help of lachesis. So here basically we can think that in acute cases also, sometimes in many a times we don't need to change the medicines, because keeping patient and not changing the medicine takes a good amount of uh, experience. In my previous means previous days of clinical practice, I wouldn't have waited so long before changing the medicine, but now, since after gaining a little bit more experience, I choose to wait and let Lachesis work itself, and it did the job well. So this was my presentation. Basically, salivary gland stone is not a disease which is commonly occurring in the clinic. So I thought of sharing this case with you. Thank you.
Thank you so much, Dr. Argo. And for the viewer, uh, the goal of today's session is to share knowledge and experiences in a very fast-paced manner and very, in fact, impactful manner. And I believe that Dr. Argo has given a justice into it. What he has talked about the Cellulitis and how the Lachesis could improve the case. Our target of today's session is to learn a particular drug, uh, whether the particular drug have a affinity towards certain disease condition or not. That we have experienced many a cases till now, and we have learned a lot out of this session today. Here, I would like to give a touch of a similar topic of discussion today that this Orgos had said regarding Cellulitis. Uh, Homeopathy in our country, very often they do come across a certain case of parotid tumor too, that we call as a salivary tumor too, that we call as a pleomorphic adenoma. It so happens sometimes that we are confused in disease diagnosis, whether this is a Cellulitis or it is a beginning of pleomorphic adenoma. A simple X-ray can say that the patient have a Cellulitis or a swelling by doing a sonography or by doing a sonography guided FNSE. One can have the idea of disease diagnosis, that the point of view that the pleomorphic adenoma is always has to be excluded into it. So thank you so much, Dr. Argo, for being with us. Next, let me call upon Dr. Vivekananda Chakraborty. Dr. Vivekananda Chakraborty is our next speaker. I'll request Argo to bring him over the dais. Dr. Chakraborty. Dr.
Good evening,
Vivekananda, very
everybody.
nice to see you.
Thank you, Prolada. Thank you very
Please,
much.
the floor is yours.
Am I audible? Am I audible? Good evening, everybody. Am I audible?
Yes.
Okay.
Yes,
Good
you
evening,
are
everybody. Thank you, Dr. Kolani. Thank you, Dr. Prolada. Thank you, Dr. Viduta. Thank you, Orko, Dr. Orko. So, as the name signifies, the topic, the calendula, an exceptional wound healer of paramount importance. So I don't know what I'm to add, because many of our coveted speakers they are delivering these lectures very nicely. At the outset, I should divide my case in three components. The first one is the case itself, as I took the case, as I did, what was the potency, what was the repetition. The second was a little bit of pathology I would like to add into the case, as I can consider myself a prescriber of the pathogenetic uh, aspects correlating with the patient symptoms or the drugs or the both. And the third point is I would narrate some of the rubrics from the repertory which I use, not most often, but sometimes, that is rather, which I use in my clinical practice. I'm a full-time practitioner. So to start with the case, she was a lady of 41 years old. She had a cut injury. I can call it a gaping wound. So it was just, I don't know, I can share the slide or not because it's not in the PDF file. Though, should I try? Can anybody help me in doing that? If I, hello?
Sure, sir. I am here to help you.
Okay. So should I go with the slides or the share screen file? Share slide. If
Just
I
go
go,
with the slides. If you have slides,
okay.
then just go with the slides.
Okay, then it is your computer. Then slide sharing tips, upload file. Can I upload? It's not in the
Yes,
PDF.
yes.
So, okay, let me try.
It will be okay. It's not in PDF, then it's on PPT or something, I guess.
Let me check. It is difficult because I am not vast in technical aspects of things. That is a point. So, 1 minute. If I can, I can see, I can show you the cut, the gaping wound.
Sir, you can just then click on the share screen. It's possible also that you can just click on the share screen and just go to the. I'm just guiding you with that. Just click on the
Share
present
screen.
again. Just click on the
Yeah,
present
share
and
screen.
then go to the share screen. It's a complicated process.
Yeah.
Then again click on the share screen.
Share screen.
Then after that.
Yeah. Chrome tab,
Yes,
window
sir.
and entire screen.
Then after, just click on share screen again.
Okay. Yeah. Entire screen.
After that, there is an interface, right?
There is an
interface where you can see there are Chrome tab, Windows, and entire screen.
Yeah, Chrome tab, window, and entire screen. Yes.
Click on the entire screen, sir.
Yes. Yes.
And then you can get a miniature version of your screen. Just click on that.
Yes. Yes.
Are you sharing? Are you sharing any video or something?
No, there's the photographs only. 3-4 photographs.
Then just click on the entire screen and click on share.
Okay. No, it's not coming.
It's currently on screen. I will bring it up as soon as you open the main context, means the picture. It's showing. You can just open the picture right now.
Okay. I should open the picture right now. Okay, 1 minute.
Yes. Just minutes.
Can you see any picture?
It's visible. Just do it on the maximize. Just maximize it, if possible.
Okay.
Now it's completely visible.
Okay. So can you see the picture and can you see the cut injury?
Yes, sir. It's clearly visible.
Okay. Let me come in the studio. Where is the studio?
You don't have to open the studio. Just click on this, sir. It's not compulsory to be on studio.
Okay. Can you see the screen? I mean the picture.
It's showing.
Okay.
Just open the picture, sir. Open the picture just.
Okay.
For privacy purpose, I'm just keeping the screen out. As soon as you open, I will just bring it up.
Yeah, it is the
it's showing.
clear
It's
one.
showing.
Just can you see it? Can you see this picture? The red cut, the red color, the cut mark, the cut one, the yeah. So
yes, sir.
As you see from the picture, this is the location. I mean the just above the upper eyelid, just near to the eyebrow, left side. So it was a gaping wound. So after securing the hemostasis, what I did, I prescribed Calendula. Calendula officinalis, simple Calendula officinalis, 1 m, which I do mostly in case of acute disease. I prefer giving high potency in a repeated basis. So I prescribe Calendula 1 m 4 times daily for 7 days. So what was my prescription? The only prescription I made, that was Calendula officinalis 1 4 times daily, that is QID for 7 days. So it was the picture after securing the homeostasis. After that, see, can you see Orko? Hello?
Yes, sir.
Hello?
You just go through with it. You just go through with it. I can see,
Okay.
sir. And the world
Okay.
can see, sir. You just go through.
Okay. So these are the subsequent pictures. And the local calendula ointment also I have applied, and the debridement, wound debridement, and so and so, which we know from the pathology or from the clinical medicine. So it was I can say it was a quick cure from calendula. Now, first point is the calendula which I prescribed, and the potency which I already told about, the 1M potency. And the second component of my case is the pathology of the calendula. I should read out some of the points from the Allen's keynote as well as Boric, so that I should not miss any point. It is clearly written in the calendula, in the Allen, to secure union by first intention and prevent suppuration. From the students of medicine, we all know what is healing by first intention and what is healing by second intention. So the platform doesn't allow me to elaborate on that, and it prevents suppuration. All know one thing, that is, in a case of wound healing, the infection and the subsequent suppuration, these are the difficult things for a wound to heal. They don't allow the wound to heal properly. The pyogenic infections, we know the bacteria, the pyogenic infections, all the strepto, staphylo, pseudo, and other also are there. Even some of the notorious organisms are also there. So I can consider these as prevent suppuration. There was no suppuration in the case. The second point, which I want to mention from the Allen itself, in all cases of loss of soft parts when union cannot be effected by means of adhesive plaster. So I am not going into the words said by the Allen. So as I told, it was a gaping wound, GAPING, gaping wound. So it was wide open. It was very difficult to make the layers of the skin from both the sides of the wound to be on the position. So it was all calendula. So now, to dwell more of the pathology of the case, I should mention some more points from the case itself. Calendula is almost specific for clean surgical cuts or lacerated wounds to prevent excessive suppuration. And the last line before the relation, Allen mentioned it and Allen emphasized it. Now I'm reading Boric. What Boric says about calendula. The most remarkable healing agent applied locally. The second point is useful for open wounds, parts that will not heal, ulcers, etc. Promotes healthy granulations and rapid healing by first intention again. Now, come to the pathology little more. So what happens when there is a wound? What happens? So there are lot of factors, as we know from the pathology, like the epidermal growth factor, like the TNF tumor necrosis factor, like the interleukin 1, like the VEGA vascular endothelial growth factor. So I have the data from researches which I can show you later on. So where it is found that calendula specifically aids angiogenesis or neovascularization. What Dr. Tirthankar told about sloughing that ulcer with the red appearance and all, with the vascularizations and all. So this is the particular point which I like to emphasize on, that is vascular endothelial growth factor. Typically, it is found in case of the animal studies, animal models, like in rats specifically, it is studied that it expresses, I mean the calendula extract, it stimulates for the production of the VEGF growth factors, and it expresses the genes which are responsible for the production of the VEGF, which is a pivot. You can say, we can say it's a pivot for wound healing, specifically for the angiogenesis part. There are other also, like I am reading from another research article. Just give me a time. This is, yes, this is anti-inflammatory, anti-edematous, antioxidant activity, antibacterial, and antifungal. Even it has some proposed activity against HIV, wound healing, and immunostimulant activity, anti-cytotoxic, and exhibited increased levels of pro-inflammatory cytokines, interleukin-1 beta, IL-6, tumor necrosis factor, and interference gamma with the acute phase protein. So by the time it is known perhaps that what calendula does in this case, because once a wound gets to be healed by the fast intention, there has to be fast angiogenesis, fast fibroblast formation, fast collagen deposition, and so on. So what is done by the calendula, I think it's evident to all what I have discussed. Now, to I am just going to complete my discussion. There are few rubrics from the from the drug which I want to mention, which I take often from in my clinical practice from the radar software. I just read on those rubrics because these are very helpful hints and rubrics for day-to-day practice. We don't need a long case taking. I cannot consider myself a classical homeopath, which I never know what to do. Even I don't know after Hahnemann who is a classical homeopath. Sorry to say, but I don't know. So these are some of the indications of the calendula which I gathered from the software radar. I just read on. Mouth bleeding, gums, extraction of teeth profuse after. Chest abscess mammary threatening in old cicatrices. Injury spine, though we all know about the spine injury, natrum sulf and hypericum and other drugs also, calendula has one mark there. Extremities, fractures, open fractures. Again, the question of open fractures, the compound fractures where the skin is not intact and the chances of infection and the suppuration and so on. Fever, puerperal prophylaxis. We know from the old pathology books, the childbed fever and all after the delivery. So it is a great remedy. We can say it's a homeopathic antibiotic. We can say it's a homeopathic bactericidal. We can say it's a homeopathic bacteriostatic. Okay. So the third one is generals chapter, injuries, contusions, concussions, extravasations. We all know from the pathology what is extravasations, operations after rupture of muscles. And I want to add one thing. I have even experienced, I do treat sports injury cases and often. So in my practice, sometimes I found or I find the avulsion injuries, avulsion, avulsion injuries, the degloving of the parts. So even calendula is very helpful in those cases. So that is the rupture of the muscles and all. The injuries, bones, fractures of compound fractures, which I have already mentioned. Injuries, tendons of. I must mention another drug in case of injuries, tendons that I often prescribe, that is Argentum metallicum. Because I do the sports injury cases, many of the football players and different players from different Calcutta teams, I get the privilege to treat them. So I'm lucky enough to give them the Argentum metallicum along with other drugs. I sometimes I give 2-3 drugs at a time on an alternative basis. It's not like that single drug every time I give. Rather, I prefer giving 2-3 drugs according to their pathogenesis to the case. When a case, when an injury takes place, you have the muscle laceration, you have the tendon rupture, you may have the soft tissue torn. So in case of soft tissue torn, I prescribe the component of calendula. In case of muscle, I prefer for a deeper impact, I may prefer Bellis perennis or so and so. That is a different discussion. It's not the purview of this today's discussion. The injuries, tendons of wounds, bleeding profusely. Freely bleeding wounds. Another very important drug is Hamamelis virginica. But the infection part, the suppuration part, the wound part, the wound mechanism and their infection and all these things and their contamination, that is not covered by the hematomas. So that is more of a different type of bleeding, which is again everybody know. The second part is wound cuts, the rubrics, wounds foreign bodies from. We all know sometimes if a foreign body is stuck in our skin or in our in a body tissue, there's a chance of suppuration. So we know Silesia, we know Vacum, even Calendula is also we can think of, which we know also Ledum. Wounds granulation, proud flares. There's a lot of discussion required for this granulation, proud flares, how the overgranulation take place. This is again the tumor necrosis factor and other factors which are responsible for. That is again not the purview of today's discussion. So wounds granulation, proud flares, it checks the overgranulation tissue as it is done by Silesia sometimes, as it is done by Thiocinaminum sometimes. There's a gunshot wound, you can use Calendula. Wounds, lacerations, wounds suppurating, wounds soft tissue torn, wounds heal tendency to slowly, it's a bottom line, wounds heal tendency to slowly. So it can expedite the wound healing process. Even that is, it is also very good for to expedite wound healing. So I hope I can give a little bit of points regarding Calendula, how good it is. It's a magic in science. It's even used in the folklore sources. When in my childhood days, I just tell it in Bengali, Gada Pata, marigold. So whenever we have a cut injury on the streets or on the playground, just the leaves are squeezed and placed over the wound, and it healed often. So this is Calendula, what I wanted to mention, and hope I expressed what I wanted to say. Thank you very much. Thank you all for inviting me in today's CME. Thank you very much. All the best. Hello.
Thank you so much, Dr. Vivekananda.
Thank you, Pritha. Thank you very much
for your very insightful presentation here. And the Calendula is widely known in homeopathy for its remarkable healing properties, particularly in wound care. It is often referred to as an antiseptic, aiding in the rapid healing of cuts, abrasion, and surgical wounds by promoting the tissue regeneration and reducing inflammation. What you have talked about. Not only in if you not only in injuries, you will find that the Dr. R.T. Cooper has in his literature, he has very beautifully has explained the Calendula to be taken for long periods orally in case of CSOM. Very often we do give this Calendula in case of neurofibromatosis too, and we often prescribe this Calendula, particularly when we get a hydrogenoid constitution in case of cancer cases. That Calendula works remarkably, in fact. Let me thanks once again Dr. Vivekananda for being with us. Now let me request Dr. Shomit Hajra to be on the dais to speak.
Okay, so good evening to all. Am I audible and clearly visible?
Yes, Shomit, you are audible.
Okay. So good evening to Praloyada, Kullanish sir, Vidutta, and all the panelists and all the speakers who have exited and on board. So I am just going to speak about a case which is about an adverse drug reaction. So what basically is an adverse drug reaction is basically somebody is taking a drug and in an unintended way the reaction comes up. So and unanticipated also. Sometimes it can flare up to can cause anaphylaxis and it can lead to death. It can be fatal, and you have to be very spot on with your diagnosis, with your diagnostic skills, and with your therapeutic skills as well. So So this is a short clinical history I want to give about of a small boy, 10 years old, and he was on a video call. Actually, his mother insisted me to take on that particular case because he resides near me, and he was not able to come to my clinic because of a certain issue, which I'm going to describe. So this child was actually had an eruption appeared on his face for last few days, and his mother told that is probably like an acne, because I was not able to see that case while he was on the acne. So, and he applied a topical ointment which he has bought over the counter. Now, after using that ointment a couple of times in the evening and before going to bed at night, the next morning, while preparing to go for school, the child started to develop an itchy rash, which started to aggravate with swelling of the face within an hour early morning. And it is so intense, erythema, and so intense stinging pain on exposure to even normal light, as in like when he is even handling the phone, or even he is in his bathroom, the small closet light also is actually causing the stinging pain to intensify. So clearly, but it was also limited to face and neck. As per the slides, it will be a slide which the photograph I'll just show you the intense thing about the whole face and neck area exposed. Now, he said as well that staying in the dark only relieved somehow, but he was actually feeling relieved by washing the affected part. So he was always going to the bathroom, putting some cold water in the face, and trying to keep it uncovered, but even not have the guts to actually wiping it, because even touching that part is also causing him enough pain. So this was a short clinical history, and I'm just trying to show the slide now, the face of that, because I don't want to on the real-time screen, like Argha, can you just show the slide? Hello. Hello, am I
Yes, sir. Just go on with the slides. Just click on that arrow button.
Okay. So can you see the first slide? That is the patient slide. You can see.
Yes.
You can see the
You can see that.
erythema.
You can see this slide.
You can see how the erythema has evolved, and after the medication, how the patient, when he came to my clinic after 2 hours, the patient has actually the fourth. If you go from the slide from clockwise pattern, the fourth slide is the normal ones after taking the medicine. So I'm coming to the medicine and the prescription part later, but this is how it is, the how intense, the how painful, and how cripping. So and it's a limitation of the movement of the person and being restricted to the home. So that's all about it, and just I want to focus on the prescription part now. So it was clearly evident that it's an erythema and the swelling of the face, and if you have to give a nosological name to it, it's obviously a cutaneous drug eruption after applying the ointment, and it is phototoxic. Now, I'll come to that later on, what could be a phototoxic and what could be a photoallergic. But it is a phototoxic because it's used for the first time, the ointment, and it happened, and it is under under the light, it is getting aggravated. So the normal signs and symptoms of the case is basically that he was comfortable while not covering the face and applying cold water, and relieved by washing the affected part. Cold water most often, left to the diagnosis is the prescription is pretty much straightforward with apis mellifica 0/1. Okay, so the apis mellifica 0/1 I gave with the second cup because it was already an intense and aggravated form. So I chose the 50 millismol potencies, and obviously with an half-hourly interval through the second cup. Okay, so and was advised to stop the medication once the improvement commences and the general relief. Now, after, as you can see in the fourth slide itself, within 2 hours, the patient came to my clinic, and the patient is normally healthy and was able to go to school after visiting my clinic. So this is all about the case which had appeared as a cutaneous drug eruption, which is phototoxic in nature. Now, something to say about adverse drug reaction, what it is actually. So now, if you can see, It is mostly, as you can see, it is mostly an unintended and independent, unanticipated response. That it is adverse drug reaction can be always immunologic and non-immunologic in nature. Now, if you think that these adverse drug reaction, mostly the cutaneous drug reactions are the most common ones, apart from other reactions. So something to tell about the mostly, if you can see in the slide, cutaneous drug reactions, which are mostly maculopapular, this is present at 46%, while the photosensitivity reaction, which is only 3% of the case which visits us in our clinic. So this is actually quoted from one of the good dermatology books, Fitzpatrick, and and one of the most deadliest, you can see, that is the toxic epidermal necrolysis, which is present as 1.3%, and you can see it is most fatal, and apart from the anaphylaxis one. So if you see, now talking about this case, these photosensitivity reactions are basically two types, as you know. This phototoxic, then this case one is a phototoxic one, because his sensitivity to the electromagnetic radiations and augmented by the external chemical. In this case, it was the over-the-counter medication, or in certain cases the specific drug. It will be an exaggerated sunburn kind of reaction with a heavy stinging pain. So and with that, obviously this does not need a pre-sensitization. It can be first time, while the photoallergic thing is an immunological reaction, delayed type hypersensitivity, where the UV rays along with the over the endogenous chemical would react as an allergen. So, and it needs a prior sensitization. So this differentiation is important to keep in mind while actually diagnosing as a quick bedside prescription, whether it is a phototoxic as well as a photoallergic. In terms of this, your prescription can be modulated as per needed. So in this particular case, obviously, as you have seen, that after giving apis mellifica 0/1, 5 to 6 doses actually he has taken, and within 2 hours the relief has happened and he was able to go to school. Now, since I have been given 5 minutes, so I have actually intended to take up only one case. However, I had only 2 to 3 more cases of adverse drug reaction, but that was systemic reactions, and that needs a lot of a bit more time, around 10 minutes or more than that, 2 cases. So I'll just end my short case here, and hope I've been able to contribute to the existing members and to the wide community who is actually listening to this. And hopefully I will also be able to learn from the participants, and actually thank you for giving me this platform to share my case and share my knowledge. And thank you all of you.
Thank you so much, Dr. Shamit, for your insightful presentation on managing an adverse drug reaction, that too in cutaneous drug reaction, in fact, in a pediatric case, particularly when the ointment use is involved. Your discussion highlighted the complexities of treating ADR cases, and we have come to know that how homeopathy can provide a gentle but yet a very effective approach to heal such condition. It's fascinating to see how you navigated this case with such care, ensuring the child's safety and well-being too. We appreciate your sharing your expertise and experience with us today. And it is very relevant topic what we have discussed today, because ADR is a part of your pharmacovigilance, and across the country we do have a movement into it. It's a flagship program of the country that the ADR has to be reported. ADR has to be reported to a particular place where the office is concerned. Thank you so much once again, Shamit, for being with us. Now, to call upon to continue the CME today, I would like to request Dr. B. Dhanalaxmi to be on the dais and to share her view, to share her talk in this platform today. Dr. Dhanalaxmi, here is your floor.
Thank you, Pralada. Do you hear me? Can all of you hear me?
Yes, ma'am, you're clearly audible. You're clearly audible. But maybe the screen, the half of the screen is black for some reason. half of your screen is showing black. Can you see that?
Yes,
I don't know why, but it's showing black, half of it.
Just 1 second. 1 second.
Okay, ma'am.
Yeah, I'll just proceed, but let me see quiet. Okay. Anyway,
you
I'll
can do
just.
one thing. Ma'am, you can do one thing. You can just keep the camera and you can just sit on the left side. Just shift left.
Is that okay?
This is right, ma'am. For me, it's right. It will be on this side. Just
this side, okay?
This side, ma'am. For the opposite side.
Oh. Okay, sorry. Come on. 1 second.
It's
One
okay.
second. I'll ask my son to rectify. Only my after.
Okay. Sure. Until now it's okay, ma'am. Now it's okay.
Yeah, thank you.
Ma'am,
Thank
it's
you.
muted. Now over to you, ma'am.
Yes. Yeah, I'm here. Thank you so much, NIH Alumni Association, once again to give me an opportunity to speak on it. And thank you, Dr. Kalyani sir. Thank you, Bidutta. Thank you, Pralaida and Argha. A great job you're doing for all of us to present here. And I see the conclave is getting very successful, and I'm so happy to be part of this. Yes, since I've given only 5 minutes, let me start immediately. I'm trying to share my screen. Yes, today I'm actually going to talk about a case. Do you see my screen? Okay.
No, ma'am. It's not yet being shared.
Yes.
We can wait, ma'am.
Yes, 1 second. Okay, I'll continue talking about it. See, this is actually a case of Calendula, which came to my OPD with a cloudy urine, which was actually, she had brought a diagnosed case in front of me. So it was already diagnosed as Calendula, and the cause of the Calendula is actually not known. Although the causes of Calendula is mostly parasitic and Viscidacea bancrofti, which we all know. And 1 second. Not.
I'm extremely sorry, ma'am. It was a completely IT glitch. It was my IT glitch. Sorry for the weird thing. It was a complete IT glitch. Please hold on, people. Ma'am is getting through with it. Please hold on. And before continuing, let me just thank to Rakesh Raj for becoming a new YouTube member. Thank you, Rakesh Raj. Ma'am, I guess you are being muted for some reason, and
yeah, I'm here.
Has been...
Yes.
Your video has been turned up.
Okay.
Over to you.
Do you? Okay. Screen.
Go to.
Okay. And do you see my screen now? Hello.
Yes, ma'am.
My screen now?
It's being seen. Yes, ma'am.
Yes. Okay. So,
whatever you do, just don't click on the slideshow.
Okay.
Because as per you have, I am seeing that you have just opened that tab option. You had to just share the screen while like doing that entire screen part. Like you have to do that entire screen option.
Okay. Can I go back and share it for you?
Yes. You can go back.
Okay. Escape. Okay.
Do the same process again. Just do the same process again.
Yes. I'm sorry. I'm taking some time. Just 1 more minute.
It's okay, ma'am. It happens. It happens while on being on stream. It happens.
Yes.
Yes, ma'am.
We can share the screen, but not the whole thing, like not the.
Just click on the entire screen, ma'am. Click on that entire screen, which you
Entire
are
screen.
sharing the entire.
Yes, yes, yes,
That,
yes. I
then
got
you will
it.
see a
Yes.
small screen, a small miniature version of that.
Small miniature version of it.
It's been showing now. You can just now click on the PowerPoint.
Do you see that now?
Now you can just turn on the slideshow.
Okay. Oh, now I can check. Okay, that's what I was trying to do. Okay.
Okay. Now it's over to you, ma'am. Just click on the hide button if possible.
Yes.
Now over to you, ma'am.
Yes, thank you. Thank you so much, Argo. Thank you. And please excuse me for the delay in presentation. This is a case of chyluria, which is reported to me with a diagnosed thing. And I'll just quickly say what is chyluria. Chyluria is a rare condition in which the lymphatic fluid leaks into the kidneys and turns the urine milky white. And let me not get into all the stuff, which is actually we will get to see in our textbooks. I will focus on presenting the case alone. There's a female who presented with thick, cloudy, creamy white urine for last 2 years. Instead of reading this out, I'll tell you, this lady just presented to me with the cloudy urine, and she was only bothered about the cloudy urine, probably keeping off all other complaints in the backstage. I did not know this till I clearly saw after the first prescription. She just was concerned only about this cloudy urine. So she came to me for this, and she told me that she's having this since menarche, and it disappeared. It got resolved spontaneously. Thereafter, it recurred after her last childbirth. So this led me to the quick prescription, and along with this, she had one other complaint which she complained. Probably she thought it is related to it, that she complained of burning in urethra and vagina when not urinating. These two things alone pointed me towards a drug. We all know burning urethra or vagina when not urinating, burning urethra when not urinating, which is clearly written in Allen's keynote. So my same Calcutta style of prescription I did, I mean like keynote prescription I did with Staphysagria. This is the case actually with the positive chyluria. You can see that clearly here. And then I gave her Staphysagria 200 OD 2 days, followed by Staphysagria on 2 consecutive days. This with this her burning urethra and vagina came down little. After that, I gave her 1 dose of thyroidinum. Thyroidinum was given on the basis of not well since last childbirth or since menarche. This change of life in women always is a good indication for me to pick thyroidinum, which has always helped me handy. So with these 2 remedies alone, the chyluria disappeared, and she was doing quite well. This, I will say that I have already had my experience with 2 other cases of chyluria. This is like kind of, I am applying specific, although it is not good to say it is a specific. I have seen that it works. So I gave her these 2 prescriptions. So you can see the clear urine and the chyluria turned out negative. And this she enjoyed for some time, after which again she came back to me saying that no, it is ma'am, it is recurring again. So please help me. Now this time she came with so many other complaints along with cloudy urine. So I asked her, please tell me what are all the other complaints, because I want to help you thoroughly. So please tell me. So she came down with some complaints like acute low backache, then dysmenorrhea, and there was menorrhagia, and again the same burning urethra, which is reappeared again. She had a profuse hair fall since last 3 months. So all this prompted me to take the case in detail. So I took her case in detail. I'm not getting into all the details, the generals. I will just quickly go through it. Heat in general aggravation. Appetite was good. Desires. She had sweet desire and fish desire. Aversion milk was very prominent. Thirst was very less, 1 liter per day. The tongue was white coated, thick white coated. These are all quick characteristics alone, which just the salient features I'm going through. This had a lot of written work. And then she had a profuse sweat in the armpits with a salty white deposit. Here you can see clearly that I've marked white and all these things. And the sweat was offensive sweat of axilla in the childhood. And then now again she had a salivation during sleep, which had a stained white in her mouth, which clearly she told me that, Madam, when I wake up in the morning, I can see clearly a salty deposit in the corners of my mouth. All this are quick gist of what I have taken the case in detail. This is not the entire case in detail. I put a lot of work into taking this case. So now with this, I tried giving the same prescription, but this time it didn't work out much. So therefore, to arrive at a larger picture, I had to consider some more things which is very prominent in the case. The discharges in this case are distinctively white in more than 3 organs. So I consider this. I am following, I'm going to apply Boger synoptically in this case. I don't apply always Boger synoptically. In this case, I tried applying Boger synoptically to pick the strain which runs in and through. This here, the pathological general with its white component, prompted me to think of it, and then I verified it. 2-3 organs, and it seems to be white in 2-3 places. So the modality morning after urine characteristic also is very important. This urine, which she told me, the white cloudy urine, is always only on the first urine in the day after waking up in the morning. This is a uniform thing which was always present throughout whenever she had chyluria episodes. Her chyluria episodes is not the first time now. This is the first time second time she's presenting to me, but she had these episodes earlier also. But the beauty here is, after working out with Boger synoptically, I took general's white, urine cloudy. I did not take mucus or milky, because here it is cloudy. The urine has a straw color thing. Over that white will give us a cloudy appearance. Mucus will show mucus in the blood test. I have all our blood test investigations and all, or urine test investigations, which I'm not able to share here because I was told it is 5 minutes, so I could produce only slides of this irrelevant. So I had taken general's white, urine cloudy, which is the reference in Boger synoptically, and urinary organs concomitant at the start of urination. Here, this is not at the start of micturition, it's at the start of urination, because every first urine which is passing in the morning after the accumulation is cloudy. After that, it becomes clear. That's what she told me. So based on this, mercurius it came out in the repatriation. I chose mercurius. I gave her Merxol in 0 bar potencies, after which she's gradually, very, very promptly improving. I was happy with that. But then I asked her one day to bring all the case reports. In the case reports, I can see clearly that you can see here she had multiple gallstones, and which is single gallstone measuring 1.5 in 1.4 into 8, and there were multiple small and soft gallstones collectively measuring 3.1 into 1.4. And again, another scan which verifies the same thing. She had cholelithiasis, mild splenomegaly. Here also you will see splenomegaly, cholelithiasis, mild splenomegaly. Here mild splenomegaly. Again, the same thing. I mean, like, it is just a few months' time. But now, after giving mercurius, I wanted to see how is her, because she had menorrhagia and dysmenorrhea, I was actually trying to look into her uterus. The previous reports of scans she did not show me, thinking that it is not relevant with chyluria. After working on the case in detail, like after giving Merxol, I wanted to check how is her status about the uterine activity, if there is anything which is really giving the menorrhagia, or if I'm missing any pathology. I can see that the report came for single gallstone 1.2 and 0.5 centimeter, and there was no splenomegaly. So the take-home message here is a well-worked-out case, when a right simulum is chosen, will act on all the pathology in the background, then just acting on the working out on the presenting complaint alone. So yeah, here I worked out on the characteristics of the case, and she could I hope she's on the path of cure. I am not concluding this case, but this is in the path of cure. The idea is a well worked out case will move towards the curative remedy, and the curative remedy can resolve all the pathologies in the background. So thank you so much for the kind invitation and permission to present my case.
Thank you so much, Dr. Dhanalakshmi. We really appreciate your contribution in today's session. And you have talked very nicely regarding a treatment of chyluria, which is in fact very challenging, in fact, because we never know that's whether what is the possible disease in the background which is causing the chyluria. In fact, we have a conception that the chyluria occurs in lymphatic filariasis, but it is true that we have seen in many cases that in case of nephrotic syndrome, that because of the compression given in the urinary general tract over the lymphatic system, that there can be occurrence of the chyluria in nephrotic syndrome. There are many causes, like a trauma can cause trauma after surgery, after facing an accident, one can have some episode of chyluria too. In case of tuberculosis, particularly in case of genitourinary tuberculosis, because of obstruction over this lymphatic system, one can experience chyluria. In case of cancer, when these lymphatic channels are getting obstructed, there again we can get some episode of the chyluria. It is a challenging one, and thank you so much, Dr. Dhanalakshmi, for giving your insightful thoughts in the treatment of chyluria today. And we are enriched. Thank you so much. Now, with the flow of this CME session today, I would like to request Dr. Kaveri Pandey to be on the dais. Argha, can you bring Dr. Kaveri on the screen? Dr. Kaveri, this is your floor. Please.
Thank you, sir. Good evening, everyone. And I would like to thank you, all the members of Alumni Association, for giving me an opportunity to speak on the 99th episode of CME among so many senior homeopathic physicians. Dr. Argha, can you please help me with the slides? Okay. So today I will be representing a case of adenomyosis. So basically, adenomyosis is a condition in which there is an ingrowth of the endometrium, both the stromal and the glandular part, into the myometrium. But what happens as a result of this is heavy menstrual bleeding, a menstrual bleeding that is more continuous even for 14-15 days. There is intermenstrual bleeding also, plus there is spotting, and due to loss of excessive blood during periods, there is generalized weakness. So this is what the general signs and symptoms of adenomyosis is. So I had a patient, usually this affects females in their 40s and 50s. And even I had the case, the female was in her 40s. So the usual treatment, that is the conventional treatment, is the hormonal therapy or removal of the uterus, that is hysterectomy. So can you please change the slide? Dr. Arko, yeah. Next slide. Okay. So even my patient came to me. She was already taking allopathic treatment, that is with from the Apollo Hospital for last 2 years, but she was not getting any relief with the conventional treatment, that is the hormonal supplementation. So she was advised to undergo hysterectomy, but she was reluctant to go for the hysterectomy, and so she turned up to me for homeopathic treatment. So her symptoms were mostly of, which is common to adenomyosis, that is your prolonged bleeding, prolonged menstrual bleeding, heavy menstrual bleeding, then pain, continuous pain in the lower abdomen, spotting, for which she has to wear pads every day, even after the period is over. This happens because the muscle loses its tone. So what happens in a normal menstruation, that after the period is over, the bleeding stops due to contraction of muscles, but this doesn't happen here. So the bleeding was continuing, and she was having pain in lower abdomen, and she was very lethargic. Most of her symptoms were like left-sided headache was there. Next slide, please. Left-sided headache was there. Then left ovaries has 2 functional cysts. She was very much intolerant to sun heat. Then nausea and vomiting was there. There was also desire for loose clothing, and the abdominal area was very tender to touch. And she was very much talkative. So based on these symptoms, I just prescribed her Lachesis and LM potency. Next slide, please. Yeah. So Lachesis 0/4 and Lachesis 0/5 we have prescribed one after another. Along with that, I prescribed China because China 30 in low potency, because she was very much lethargic at that time, and we know that China, and there was bloating. She was not able to eat anything properly, and due to the hormonal therapy which she previously took, she was even more feeling nausea and vomiting, episodes of vomiting, severe headache. She was not able to tolerate those medications, and there was profuse blood loss. So for that, I prescribed China in low potency. The patient was doing well after a month. So the next period was normal. She was not having that heavy menstrual bleeding, and it was a normal period. But after a few days again, she called me up and told me, no, the bleeding has started again. So this time, I thought of prescribing Thuja based on presenting complaints, and we know that Thuja acts very well on the genitourinary organs. Again, Thuja is a left-sided remedy. This time, previously she had hot flushes. We know Lachesis acts very well in the climacteric period, and this time she was feeling chilly. It was left-sided again. Cyst was also in the left side. So this time I prescribed her Thuja. Next slide. Again in LM potency, along with Trillium pendulum to control the bleeding. As she was having very much heavy menstrual bleeding, so Trillium pendulum and Thuja were given. The next time she came, she was better. She was not having that much heavy menstrual bleeding, but some episodes of spotting were there, for which she has to use again the pads, and she was not very comfortable with that. So the third time she came, her headache was still present. So she was complaining of severe headache this time also. But so after taking a thorough case, she told me that she needs a lot of pillow below her head when she's, because I was not getting any other symptoms. So on inquiring, I found out that she used to take many pillows under her head during the headache to relieve the headache. So based on this symptom only, I prescribed her gelsemium, and we know that gelsemium acts very well on the generalized weakness, muscular weakness, and lethargy, and also there is sun heat intolerance in gelsemium. So this time she is doing well, and there is no heavy bleeding episodes. She is doing the regular follow-ups and getting regular periods. So this was my case. Thank you.
We have heard from Dr. Kaveri Pandey. Kaveri, congratulations, and a very insightful presentation you have given here today. Adenomyosis is a very difficult one to improve, and I would like to thank that you could avoid for the patient the HRT as well as hysterectomy. The challenge, this adenomyosis treatment is very challenging because of one phenomenon, that is the inflammation and the scarring. There is continuous inflammation, more of scarring makes it a very complex one. And if somebody have adenomyosis, then gradually the symptom and sign increases. If you can keep the patient in standstill, that it does not progress, that is again a part of treatment, in fact, because this adenomyosis treatment is a difficult one because of recurrent inflammation as well as scarring in the in the organ. So we could, by homeopathy, we could avoid the HRT as well as the hysterectomy. And here we also find that there's a beauty of homeopathy is that a case of Cellulitis by Argha was treated by Lachesis. Again, a case of adenomyosis is being treated with Lachesis. One medicine in different part of the organ and in different diseases we do apply. Possibly that is the strength of homeopathy to showcase today. And with this flow of conversation or talk today, to in this today's CME, I would like to call upon a very interesting speaker today, Dr. Shubhamoy Sharkar. Our next speaker is Dr. Shubhamoy Sharkar.
Good evening, sir.
Good evening. Good evening. Shubhamoy, this is your floor today.
Thank you, sir. Thank you. Argha. Okay. So, am I audible, right?
Yes, sir, you're clearly audible. Yes, Dada, you are audible.
Okay, okay. Good evening, everyone. So, today my topic of discussion is the journey of infertility with homeopathy. So, I will just directly show some cases, not going in deep because time is very much short. So, first I will start with extreme low AMH. In modern science, in allopathy sector, the doctors used to say that if AMH is below 1, then it's very difficult to treat and the IVF is the only option. Otherwise, you can't do anything. And patient come to us that we don't want to do IVF. So what is the option now? So in homeopathy, we can offer such cases like if it is 42 years also, if it is AMH 0.06, yes, extremely low. It tends to 0 only. So in that case also our medicine acts well and the patient can be pregnant. And this lady, 42 years old, when she was 30 years old, at that time also the doctors from modern science, they have told you have to adopt. Without adoption there is no other choice. But through our homeopathic medicine, now everything is fine. Anomaly scan, if NT scan, double marker, everything. So like that, this one is 41 years old case from Howrah. She is herself a health worker, and in that case AMH was 0.15 and after that it was 0.22 after homeopathic medicine. And the month where I did the folliculometry, then I found only 2 antral follicle present in the left side of the ovary. And with that ovary, with that count, and with adenomyosis of uterus, with oligofollicular, the patient got pregnant. And in her case also, both NT scan, double marker scan, anomaly scan, everything is fine. Patient is continuing her pregnancy now. This case, the most toughest case, I should say, 21 years after, married for 21 years, 5 times she had undergone IVF, and that IVF was done in front of our NIH hospital, just behind the Shushrut hospital. There is one fertility center, and that renowned doctor, now he is no more, he has done 5 times IVF. But when I found the case, I got 6 numbers of uterine myoma. All 3 types were there: subserous, submucous, and intramural. And both the tubes are opacified fallopian tubes. And also she had migraine throughout the years. So after homeopathic medicines for at long term, like 2 years, after that she got pregnancy positive. And in this case, I have earlier in my 49th CME session also, I have discussed a few rubrics related to that. And through that concept only, I have cured this case using Lachesis from 30th potency up to CM potency subsequently, which I have learned from my mentor, Professor Dr. Rompia Mishra ma'am. And along with that, I have used Auramune, Netronatum, Fraxinus americana, mother tincture and all. So this case also got succeeded after 2 years of homeopathic treatment. This was another case where 10 years the patient has to wait
IVF has been done by one reputed doctor from Kolkata. In that case, AMH was high because bilateral PCOD is there. Also, bilateral tubal block is there. Defective folliculogenesis. Defective folliculogenesis means the follicles, the eggs present in the ovary are not maturing. It should be around 2 centimeter by 2 centimeter, but it's not going up to that extent, and before that only. And in this patient, this patient, the period is very irregular, like 3 to 4 months after. And after starting my homeopathic medicines also, 2 to 3 months it took. And after seeing such cases like PCOD where irregular menstruation was there, I have used so many mother tinctures also, but I learned somewhere that our mother tinctures are not sufficient enough to bring down the period in such difficult cases. Only higher potency medicines I have got result. I have used Pinus lambertiana, I have used Senecio, I have used Damiana mother tincture, but nothing as such helped me. But higher potency medicines, selected constitutional medicines have helped me a lot. So in that case, just 1 month before this baby girl was born, 3.3 kg in National Medical College, Kolkata. And this case, that is just 2 days before I have got all the report. This is a case of premature ovarian insufficiency. We have heard, and a few days back also in NIH Alumni Association group, a discussion was going on in premature ovarian failure. But this is a case of premature ovarian insufficiency. And it was in USG report I have got that both the ovaries are atrophied. Whatever I have written, that exact thing was written in the ultrasonography report. The decreased follicular count without any follicular dominance, poor ovarian reserve, ovarian insufficiency. It was in 30th June 2023. I have taken the case on 7th of July 2023. So in this case, the main symptoms of atrophied ovary and ovarian insufficiency is that extremely low libido because of estrogenal problem. In that case, the patient was having at that time, on right ovary contains only 2 cc of volume, left ovary only 1.39 cc, extremely low, and it was written that both the ovaries are very much small in size, shrinked. Low AMH 0.69. After 4 months of treatment, that AMH level increased through homeopathic medicine only. In November, when I did, and then AMH was 2.16. And the patient also having pituitary nodule, patient also having hypothyroidism, patient is also having pituitary nodule, patient is also having bilateral fibrocystic breast disease and ductal ectasia of bilateral breast. Along with that, the husband also is having asthenoteratozoospermia. In that case, the husband was having the semen count only 7.5 million, 7.3 million per ml. Morphology was 0, normal morphology. Not a single semen was morphologically good. Progressive motility was 7%. After 4 months of homeopathic treatment, from Roy and Trivedi, I have done the semen analysis report, and I have got at that time 14.2 million. Normal morphology was 6% at that time after 4 months. And after that, I didn't do any semen analysis. But it's known that if 4% above morphology is there, then it is normal. But progressive motility should be around 32, more than about 32%. But at that time, I have got only 15%. And I have continued all the medicines. And medicines was prescribed in this case for male: acid phos, X-ray, titanium, natrum salve, caladium, staphysagria, fluoric acid, like that. In 14 months, this case took 14 months from 7th of July 2023 to this August also I have seen both of them in Kolkata, in my Kolkata clinic. And after 4 to 5 days, when I back to home, then I got the positive result that both that USG was in USG single viable fetus of 6 weeks, 5 days, I think. Fetal heart rate was 140 beats per minute. Earlier, 4 to 5 years back, she had one pregnancy, but that was miscarriage, got miscarriage because of blighted ovum, because no cardiac activity was found. And in that case, beta HCG is 16,765 in 5 weeks, 1 day. So through this case, actually, it's completely, we can say that where allopathy cannot do anything, they have only one option, IVF, and that also many a times they got failed. But through homeopathy, we can give miraculous result to the medical fraternity. So this is a case where now in ultrasonography, it is seen that both the ovaries are completely normal in size and ecotexture now. And now I am continuing in case of female thyroidinum in LM potency. In pregnancy also I am continuing this medicine, and also I am continuing uforinum in 1M potency. So last one, that case, just I want to showcase another one. This is a case of a twin pregnancy. This patient is also had at that time hypothyroidism, right-sided partial tube block, defective folliculogenesis. That means follicles are not maturing enough, and low MH, again low MH, 0.85, and they have advised them for IVF. And after 4 months of homeopathic pregnancy, that two boy child born during this Rath Yatra. So in this way, I can say that homeopathy has much to do in terms of infertility, and we should give more focus, and we should do more research on this field, so that we can at least have a protocol, because after 6.5 years of practicing, it's very difficult to set any fixed protocol to treat infertility cases, because new cases demand new kind of a new angle of prescription. And at last, I will just quote my mentors, what my mentor, Professor Dr. Rompriya Mishra ma'am used to say, that never get afraid of by the name of the disease. Just give your best and try accordingly. So thank you very much. Thank you all. Hope you have enjoyed this CME. Thank you.
Dr. Shubhamay, it was a quite inspiring talk in this platform today. We appreciate your endeavor in your clinic and your hard work for your infertility clinic. And I believe that if it was open stage today, there been a round of applause for you. And on behalf of this Alumni Association, we wish all the best for your upcoming endeavor, and to get more of success in such difficult, challenging cases of infertility. You have talked about the low AMH cases, which is again a very challenging one. And in fact, whenever we get stuck somewhere in relation with infertility cases, we do call you and keep in touch, and go ahead. And this is a fantastic experience you have showcased here, as well as you have showcased the potential power of homeopathy in this platform. Thank you so much once again. I'd like to call upon our next speaker, Mohammad Naeem. Argha, can you bring Dr. Mohammad Naeem? Hello, Dr. Naeem.
कैसे हैं दादा? How are you?
एकदम ठीक ठाक. We are very eagerly waiting to hear from you. Very experienced physician.
Actually, this is a very good time, and congratulations to all that we successfully completed this 99th. We are going to complete this 99th CME.
Sir, your audio
very
is
simple case. I'm
bit
going to present. Yeah.
slow.
Yeah.
Sir, your audio is bit slow.
So what to do?
Maybe it's due to the connection error. Can you just rejoin again if possible?
Yeah. I'm trying to. Okay.
Just rejoin again once. Viewers, please hold on. Sir is rejoining. It will take some time, but you know it's network constraint issues. So we are facing this. Just wait on for a few moments. And until then, just taking one more thing. If you have any type of doubts regarding any of the speakers, please don't forget to just ask it on live chat. It will be taken up on screen as soon as it ends, and it will be guided to you. I guess sir has came.
Yeah. Got me, Argo?
Yes, sir. Can you just say one thing?
Yeah. Now my voice is okay.
Stop once. It's bit slow yet, but it's okay. It can be heard.
Acha. Yes. I'm trying. Kindly share few pics I have shared with you. First few. Okay, this is a case of Alopecia universalis. This is after, I think, this is this one, last one. Yeah, this is a girl of 11 years age, and she is suffering from alopecia universalis since last 5 to 6 years. And at the age of 5-6 years, she started losing her hair slowly. And after 6 months, she was completely bald, and her eyebrows, if you can see clearly, her eyebrows and all body hairs were shed. And since last 6 years, she has no hairs on her body, even a single hair follicle was not there. So this is a very simple case. I started simply taking case taking. I did a simple case taking, and the few symptoms were that she was very filthy, never want to take bath, and was a little bit lazy, and she always craves for sweets. And this was a very simple case taking, not done in very detailed way. And sulfur was the drug which I came to know that sulfur will go with this. And I started sulfur 0/2, 0/4, 0/6. And after giving 3 months of sulfur, she started showing her hairs. Next slide, Arko. This one is next, and after 6 months is next. Next slide. This is the current slide, and she is now having complete hair follicle growth on her head. And the case is very simple, and I started with sulfur 0/2, simply taking few symptoms of her, and now she is in front of you, and she is having all the hairs. Actually, alopecia areata is a very tough disease, and it is a kind of basically autoimmune disease, and really it is tough to treat. But if you get a drug with good symptom matching, you will get good results. Sometimes we take thousands of symptoms but unable to cure a disease, but many a times we just take a few important symptoms and we are able to cure a disease. And this was a very simple. I did not work very hard for this case, but this is a simple case and I represented this. And the main thing is simplicity of homeopathy is very important. If you go in collecting thousands of symptoms and not getting a case done in a very complicated manner, I think simple case taking and simply going through this drug searching is very important. And I think I'm concluding in a very small way. And Arko, I did this. Okay. Arko? Arko?
Orko might be in the backstage
Yeah.
yet.
Yeah.
Dr. Naim, it was excellent that what for
Actually,
we are
brother,
today.
it was very simple.
Yes, yes, but it's interesting and very insightful that you have seen the first slide. There is no wear, and the patient remained for in such condition for a couple of years, and after the homeopathic treatment, the hair follicles have started coming, and I believe that by this time the hair will be full. You have shared your experience, your expertise, Dr. Naim, today, and it was very inspiring for all the audience who are viewing this webinar today, and those who will be viewing this webinar in near future in the YouTube. It was informative. A challenging case like alopecia totalis. We also come across very often the cases of alopecia areata too, and we have seen that this alopecia areata improves with the homeopathy treatment. Sometimes we use certain external medicine as well as the constitutional one, and that does help the patient to grow with the hair follicles. Once again, I would like to thank Dr. Naim for being with us and and for sharing his expertise into it. I believe that in near future we will listen from Dr. Naim his expertise because Dr. Naim is a very expert person in this field today. Thank you once again, Dr. Naim. I believe that we are on the end stage of our webinar today. Right now, I believe that our last speaker is waiting eagerly for long periods, and he might be very eagerly waiting for us to be on the dais. To continue this CME today, I would like to call upon our next speaker, Dr. Mohammad uh, Parvez Khan. Uh, I'll request Orgo to bring Dr. Parvez Ahmed Khan.
Hello.
Dr. Parvez, here is your floor.
Hello, Prada. Thank you,
Yes,
Prada.
yes.
I am audible? Okay.
Yes, you are audible.
Okay. Orko, please share the slide. Orko? Orko?
Sir, working on it. Just a minute.
Okay. Orko? Okay. Hello? I am audible?
Yes, sir, you are audible, sir. Over to you, sir.
Okay. Now I present a case of Mr. Bappa Molla. He is suffering from multiple pathological case. Basically it is a surgical case. The patient having the problem of fatty liver, gallbladder stone, kidney stone. There is hydronephrosis, and there is a hydronephrosis, and there is a right ureteral lithiasis. Patient having the multiple calculi. You can see the case. I am just present. Actually, my laptop is not working, so I just shared the picture of that previous report of the USG. Yes, you can see in the screen. I can't see it properly, and it's very small in my mobile. Okay, there is the multiple calculi in the different sizes noted in the right kidney. Average measure is 0.7 centimeter with mild hydronephrosis is seen. That is in the right ureter. There is one calculus that is size is 0.74 in the lower ureter region. For that, there is the ureter is dilated, and patient having also gallstone, the minimal sludge noted in the gallbladder, and patient also having the fatty liver. Patient when patient came to me, he was suggested for surgery, but patient came get reference from me and came to my clinic. When I saw the patient is severe pain, it's agonizing pain, patient can't sit. for a long time. So agonizing pain, and there is the strangury is there. There is a problem in micturition. There is the hematuria sometimes. So I analysis the case, and there is a vomiting also. Whenever eating anything is a vomiting, but the patient having the symptom that vomiting relieves the case. So I think this is the case of Nux vomica. I prescribe him Nux vomica. Along with that, I prescribe hydrangea. You can say the hydrangea for the pain relief. After giving the first prescription in Nux vomica in 0/2 for BD and hydrangea cube, 10 drops thrice a day, and patient was asking for a report B after 10 days. Patient come after 10 days. Patient was very happy. There is no pain, nothing else. I was advised the patient to take plenty of water. And one thing I advised my patient used to, that is the kulthi dal. It is very good for the stone, kidney stone and gallbladder stone, which is a dissolve it. After the this prescription, then patient come, there is no pain. So I go for another dose of Nux-Vomica 0/4, 0/6 for this is the continuous for till 0/10 for 3 months. And along with that, I prescribe Calculated Renalis 3x. And patient is after 3 months of treatment, you can see the after report. Orko, please see the next report slide. Orko, yes. There you can see there is the no sonological abnormality is seen in the present USG. Patient is already very happy. Within 3 months, patient cured. So my point is that don't bias or don't afraid of any pathology. If there is the pathology is there, no issue. We can treat the patient very easily. This is our bread and butter, the surgical cases. So we should take this case very seriously, and just symptomatically you can treat, and the patient will be happy, and patient will cure very quickly. More about the surgical cases. Thank you. And regarding the calculated analysis, my boss, which I learned from the calculated analysis, that is Polaida, is here. So I asked Polaida to elaborate further. Okay. Thank you. Thank you, everybody. Okay.
Thank you so much, Dr. Pavich, for being with us today. And I do have one question to Dr. Pavich, that you said the patient have nephrolithiasis. And
Yeah.
let me know that whether there was a gallbladder stone or it was a sludge.
It is sludge.
Right.
Sludge.
Thank you so much. Thank you so much.
Actually, yeah, it is a very, actually, the picture is shown. It is very small. That is I just WhatsApp
Yeah.
yeah.
Yeah, I
My
could understand.
laptop is not working. That's why. Okay.
I
Sorry
understand.
for that. I present the everything in laptop, but all of a sudden it's not
To
working.
continue the speech as a moderator, what I would like to share is that if there is a stone in the multiple organ, that becomes a complex, that becomes a difficult one. Renal calculi, uretary calculi, bladder calculi, we can manage. We can manage in maximum of the cases, and we can avoid the surgery too. But the challenging is gallbladder stone. The gallbladder stone is a really challenging one. Very often we have to ask the patient to go for a cholecystectomy. But for the diagnosis purpose, what I would like to share is that if we get a stone in multiple organs, means the stone in pancreas, the stone in gallbladder, stone in kidney, etc., then one possibly have to check the level of parathyroid hormone, because you all know that hyperparathyroidism that leads to excess of the calcium in the blood, and that leads to multiple organ stone, and that one has to check. Another congenital issues we do have, that is a genetic disorder. Sorry, it's a genetic disorder we do have. That is we call as a cystinuria. The cystinuria cases that causes the kidney stone due to excessive secretion of the cystine, and in some cases the stone may be also found in case of in different organs, like gallbladder, like in pancreas. So we have to be careful regarding the disease diagnosis. And Dr. Parvich has very nicely has explored his speech that how acute abdomen along with the nephrolithiasis been tackled with the homeopathy within a short period of time. Thank you so much, Dr. Pravesh, for being with us. I believe that our all speaker distinguished alumnus who have been speaker today have spoken, has given up their expertise, and it was quite informative for us. And we are delighted. Our viewer is delighted, and our viewer who will be watching this session in near future will be benefited out of this scientific seminar today. Actually, we are on the plan that we will be organizing this kind of informative session in near future. We have talked with the executive committee members that we are, if the executive committee member decides that in upcoming days, in upcoming seminar, if we can share more of such cases, that in short period we will share our expertise, we'll share our cases, the success stories in this platform, and everybody can learn out of this. Our target today to showcase the power of homeopathic treatment. To some extent, we have explored it, and I believe that this discussion went very well. Then we have 14 numbers of speaker today, and it took around 2 hours to complete this session. Now my part is over as a moderator. I would like to thank all the participants, all the speaker out here, all the viewer out here, and I believe that in upcoming days we'll see you again. Thank you so much. Thank you for being with us. Thank you so much.
So one thing I want to mention, Dr. Kaveri just missed a single part. So can she just take us time to just present it, if possible? She is asking for permission
Yes.
from you all.
Yes. It won't take much of the time. So Dr. Kaveri, please.
Thank you, sir. Thank you for giving me 1 minute. Argha, can you please show the last slide? Sir, this is the slide which I wanted to show. This is the first transvaginal sonography.
Yes.
Yeah, this is the first transvaginal sonography which shows that there was a bulky adenomyotic uterus and a collection in the lower cesarean section. Along with that, there was collection in the endometrial cavity and 2 functional cysts. Can you show the next slide after the treatment? Yes. So this one shows that there is only mildly bulky uterus and there is no other significant anomaly present. And the patient is doing well without even the hormonal therapy.
Thank you once again, Dr. Kaveri. It was excellent. You talked about the adenomyosis, and you could avoid the HRT as well as hysterectomy. It's a wonderful one, and I believe that you will do well. And best of luck for your new clinic. Thank you so much, Dr. Kaveri. To continue my talk in this session, once again, I would like to thank everyone who have participated. My turn is over. Now I would like to hand over this floor to Dr. Kalani sir. And I believe that Dr. Kalani sir, in conclusion, will do the justice to this session today. Kalani sir, please.
Thank you, Dr. Sharma. Many thanks for nicely organizing and moderating the session. In my opinion, this is one of the gem CME among these 99s.
Thank you, sir. Thank you, sir.
This Centurion CME is really excellent.
Thank you.
And all of us obviously has got multiple stimulation from different corners. That yes, we can do it. Unbelievable cases can be curable by homeopathy. Anyway, and this seminar has become more fantastic by the presence of 2 heads, second head of the National Institute of Homeopathy. Then next to director, the academic in charge and hospital in charge, they are present in this seminar and they are conducting. It is our Good luck. This would be a memorable seminar. Many of us will reserve and infrequently go through these seminar successes by which will be inspired by different cases. So whatever you learn in the literature, whatever you listen from others, but once you see the cases getting cured completely by homeopathic approach, the maximum inspiration and courage should be from those information that yes, we can cure. So many thanks to all the speakers for their coming before us, presenting their experiences. And I request to all the alumni that please come forward to share your experiences to make not only us, but to keep homeopathy keeping its head up, that yes, we can. Homeopathy is not a science to neglect. Anyway, so all are welcome. Whatever you are having, single case, minimum case, small case, to present before us, to encourage all of us and to help the homeopathy for meditation, and to specially help the homeopathic profession to become confident that, yes, I have seen these cases can be cured. What happens exactly, once you see one thing, these are the experiments. Once you see the success in your experiment, one cases, we get inspiration for 100 cases. Whatever cases we find in infertility, whatever cases we find in the critical cases of renal disorders, renal failures, will be encouraged by remembering this CME, that yes, we can, we have to strive. We should be more courageous, more strength to study, to consult with our fellow mates, brothers and senior juniors, to give relief to the patient, to give homeopathy gradually up and up. So many thanks to all of you. You are gem for the system, and it is our responsibility to take the homeopathy to the extreme. That is, homeopathy is a system of medicine for incurable, rejected, refused cases in this world. Thank you very much. It is too late. I think it is the lengthiest CME among these 99. Vidut will be able to tell it about 3 hours. Not a matter of joke, and very interesting. Up to the last moment, you are listening sincerely. Anyway, many thanks to all of you. Please come again and again and again to encourage us, to encourage yourself, and to encourage whole profession. Thank you very much.
Thank you, sir. And we are really proud to announce that till now, late 11:05 in the night, 23:05 hours IST, we are having 298 live viewers. That's the power of homeopathy. 298 live viewers. I am observing on the YouTube studio. I didn't get the count of the Facebook live. So it's excellent. And I am really thankful to the teamwork done by, though led by Dr. Pralay. He had made this concept, that conclave of clinical case presentation, and it has been done successfully. 14 different speakers, 14 different speakers, 14 different topic, and speaking up on this, Kalyani sir, you will be proud to see that you, after Pralay's retirement, after a few more years in NIH, there will be another person to carry on with the legacy like you.
Definitely. So, we are eagerly waiting to get relief from the NIH.
And I am really proud. I am really proud to get so many 14 learned persons, the young generation to the seniors, and also my dearest friend and one of the senior most respected speakers in the homeopathic galaxy now, Dr. Pralay Sharma. And he has taken all the pain to continue there for last 3 hours, 3 minutes, staying in the studio in this within this small framework is very tough. And
thank you so much. Thank you so much.
And till now, sir, the viewers count had gone 300. So with this, we are closing. We are closing tonight. Thank you, all the viewers.
Thank you, thank you, thank you.
And with this, we are returning back to Orko in the backstage editor. Thank you, Orko, for your patience since 7 p.m. till 11, 4 hours. We have been here for 3 hours. You are here for 4 hours. Thank you.
Yes, so Orko deserves a round of applause, Dr. Vidut. Thank you so much for being with us.
Definitely.
Thank you.
He is not only our son, he is our director in the CMEs.
Yes, he deserves.
Thank you, sirs. Thank you all.
May God bless you. Proceed.
Thank you very much.
Thank you, sir. Thank you.
Thank you.
So,
Thank you.
thank you to all the speakers who had been on this CME today, and to all the viewers who are watching live. Thanks for joining in, and we will see you in our next 100 CME, which will be on, I guess, on 8th September, and it has some things to in back. So be ready for the 100 CME. And still, if you have not joined, means if you have not joined yet, thank you for the lovely comments, everyone. Thank you, Ompia ma'am. Thank you, everyone. So if you have just not got your e-participation certificate, it will be live till for 1 hour more till 12. So you can just go and get the e-participation certificate. And while you are watching this on the recorded version, let me just tell you, since you are watching on the recorded version, I don't know which time are you watching. If you are watching on 25th August, in 25th August before 12 a.m., then you will be the e-participation certificate will be on screen. And if you're not watching, if you're watching later than that, then it will take, means the e-participation certificate will be not there. So, and also I hope you have come here with the, I am talking about the recorded people who are watching this on recorded version. So basically, I hope you have got the part where you can just click over here and go through the other particular cases. Like I have mentioned, I will be mentioning, this is not for the live, but the recorded. I have mentioned the time sticker for each and every cases, means every speaker who has shown it. So just waiting for more. And with this, if you have not liked our Facebook page, do make sure to like it, and do make sure to subscribe our channel for more upcoming updates if you want to see more CME like this. And again, once again, you can join in our X stream. Today we were unable to live stream on X, means the X handle, which was previously named Twitter, those who not know by right now. So thank you all. Thanks again. And we will see you on our next CME. Until then, it's me, Orko Mukherjee, leaving. Good night to all of you.